Good morning, everybody. Welcome, and we're really excited to have our final presentation by our interns today. For those of you who may not know, all of our UCSF interns take a special project that they want to work on over the year, where they do some in-depth work and in-depth analysis, and they work on these presentations. And one of the things that we have the opportunity to learn, both from our outgoing interns and our incoming interns, really get a sense of the kinds of things that they're going to get exposed to and what they're going to learn over the coming year. So we're going to see sort of what their current jobs are and sort of what the particular research project is. And I've asked everyone, and I want to remind people that I want you to start your presentations by telling us the most important thing that you've learned over the course of the year. So we are really excited to be able to launch so many of you on your careers in science and in medicine or whatever field you eventually wind up in. And we're really very grateful for the time that you put into our program and to helping us be successful in advancing the state-of-the-art of breast cancer care and screening. So, our first up, I presume, is Priyanka. Oh, and just one other thing I wanted to say is that Amy Babel, who has actually created an endowment, the Amy Babel Leadership Fund, actually allows us to administer the program, but we're very grateful to her. She unfortunately could not be here today. She usually comes to our final presentations. But we know that this video will be available, and Amy, we hope you enjoy all the presentations and are proud of all the work that your interns are doing and all of the future gifts that they will bring to the field of science and medicine. Thank you. Priyanka, without any further ado.
All right, so my name is Priyanka Narasimharaj, and over the past year I've been working as the Program Management Office of the Athena Breast Health Network. And for those of you who don't know, the Athena Network is a research and care collaboration among the 5 UC medical centers, and most recently Sanford Health, which is a system in the Dakotas. And my work this year has focused on our new biggest initiative, which is the Screening Wisdom Study, and to understand how we can use a coverage with evidence development model to push forward a paradigm shift in breast cancer screening. So just a brief overview of my presentation. I'll first describe the problem at hand and then go into the opportunity that we've identified for improvement and innovation in screening and in coverage. And then I'll focus more specifically on the work I've been doing this year, specifically with the health plan Blue Shield of California, in terms of implementing this for our wisdom study. So as many of you know, and many of you in this room work on clinical research at large academic medical centers, despite the good intentions of those who are involved both with the research side and the decision-making side, there's still a very significant gap between research findings and actually implementing those results into standard clinical practice. And of course, there's a number of reasons for why this is the case, and a lot of those are outside the scope of my presentation today. But I did want to focus on one significant aspect, and that is limitations by most health plans and Medicare and Medicaid on covering investigational services that are being provided in clinical trials. And this is, of course, plausible because covering an investigational service is risky. But at the same time, without covering a service that we haven't tested yet, how will we know if it actually can be used in clinical practice and benefit the patients who stand to benefit the most? So, given this coverage issue, a potential solution that has been identified in the past is something called coverage with evidence development, also referred to as CED. And this is basically a policy that allows for the coverage of promising investigational services, again, usually provided through a clinical trial, with the idea is that as we're covering these services, we simultaneously collect data on how safe and effective the intervention is for patients, and then use this data to inform future more permanent coverage decisions. And ideally, this would enable a very learning-based healthcare system because we would have coverage and research happening simultaneously as opposed to coverage lagging months or even years behind the research results that show that an intervention is effective and best for patients. And historically, coverage with evidence development has really been in the domain of CMS, or the Centers for Medicare and Medicaid Services. It was first used as a concept in the mid-90s for one procedure, and in 2005, CMS wrote out a very formal coverage with evidence development policy, although it was primarily theoretical in nature and not applied to a specific intervention. And in contrast, most commercial health plans don't even have a formal written CED policy, let alone one that's implemented for an intervention. So given the lack of CED policy implementation in commercial health plans, a potential opportunity for innovation has come with the Patient-Centered Outcomes Research Institute, often referred to as PCORI. And this organization was created by the Affordable Care Act and basically seeks to address that issue that I talked about at the beginning of the presentation, to make sure that these results that are being constantly churned out in research are actually going back to the patient. And obviously, in the title itself, patient-centered implies that it has a real sort of dedication to making sure that this goes back to many patients who stand to benefit. So in spring 2014, PCORI did something relatively radical. They put forward an inaugural funding announcement for large pragmatic trials. And they had several requirements for what these trials would need to be. They had to evaluate a meaningful intervention in a relatively short amount of time. 5 years is pretty short, considering that a lot of survival outcomes and things like that often take decades to track. So they wanted a design that would facilitate being able to understand at the end of 5 years whether or not an intervention would actually work. They wanted to make sure that if this intervention was proven to be successful, that it could be implemented in the clinic and larger community, not just a large academic medical center, in a relatively short amount of time. And in terms of the funding requirements, they were offering up to $10 million in direct funds for implementation and monitoring costs only. So, notably, no clinical service could be covered by PCORI funding. That had to be solicited from working with stakeholders and health plans on behalf of the research organization. So the Athena Breast Health Network took this as an opportunity to tackle a very controversial and frequently talked about issue, which is that of breast cancer screening. It's something that's been mired in controversy, especially over the past couple of years. And we really wanted to design this study to put to rest the debate and understand whether annual screening, so annual mammography, or a risk-based screening approach that takes into account a woman's individual risk profile is more safe, more effective, which is more preferred by patients, and ultimately which has the bigger potential for cost saving as well, while also avoiding the issue of overdiagnosis. So we designed this trial and we're hoping to enroll 100,000 women over 5 years, which is no small feat. So in terms of understanding, we had this trial, but we still had the question of how do we make sure these services that we're providing to patients who are participating are covered by health plans, since PCORI is not agreeing to fund these services, partially because they want us to develop a sustainable mechanism for funding, and also because we don't want patients to be paying out of pocket for any services if possible. So our proposed solution was to package our Wisdom study services in a very easy billable way to identify codes that could be processed by claims and ensure reimbursement would happen smoothly. We wanted to then approach commercial insurers, self-insured employers, and ultimately CMS as well, advising them to use a CED-type approach to cover those 4 services that we provided to them with the codes that we thought would work for them. And then lastly, because we were doing so much that was already new, we wanted to make sure that, given this extremely complicated world of billing, that we could minimize the overhead costs, the pre-authorization issues as much as possible, and also importantly, make sure that these funds that were being provided to us in exchange for the services that Athena is providing through Wisdom comes back directly to Athena. Athena, of course, is housed under the 5 different medical centers, but it's also a research collaboration that transcends that structure. And each medical center has its own rules and regulations around fee schedules, and we wanted to avoid being trapped in that as much as possible. So just to give you an idea of what those covered services actually entail, here's a table that describes them. I want to draw your attention to the fact that services 1, 2, and 4, which are related to risk assessment and counseling for high-risk women who are identified in the trial, can be considered preventative services. So while they might not be routine in the community or clinic, a lot of the health plans that we've talked to have considered these relatively standard of care and would be willing to cover them, assuming that the codes that we have provided for them will bill. In contrast, service number 3 is a comprehensive genetic profile, which basically all women in the risk-based screening arm will take, and it'll help them determine what their genetic risk for cancer is, and also inform the screening recommendation. And this has never been done on the population level, so all the health plans that we've talked to have pretty much identified this service as investigational. So this is where a CED policy for coverage would fit in. And I've included the costs here. They're definitely still in the process of being finalized, but just to give you a sense of how much we want for each of these services, it's based on our previous conversations with multiple health plans, as well as what costs are needed to keep Athena up and running. So in terms of actually understanding how do we make this happen, this proposed solution happen for the work that we've been doing, I wanted to sort of draw your attention to a metaphor that some of us have started using, which is the idea of tearing down the brick wall. Tackling this extremely complicated issue of billing among 6 different medical centers and making sure that these services provided in a clinical trial would be covered. We've done a lot of work with our one specific strategic partner, Blue Shield of California, and wanted to take you through sort of the specific and innovative work that we've been doing to sort of break down those barriers that we've encountered along the way. So the first major thing, and also one more thing, one of the things I learned this year was Dr. Esterman's penchant for PowerPoint and little graphics, so I've tried to implement that here. So the first big accomplishment for us was in December of last year, and this was Blue Shield actually writing a formal global CED policy, as well as one specifically for Athena and for the Wisdom trial, and then having their board approve this policy. And that was a huge step. It definitely been something we've been building up to, but without this, nothing else would be possible. So it was really the first step. The second step was that we established Athena as a virtual office under the UC Office of the President. And that might not sound like something that's particularly innovative or interesting, but really what it means is that Athena is centralized under the UC Office of the President, has the authority to sort of conduct these services among the 6 centers that we will be working with, and furthermore, ensure that we can bill as a provider. Athena, of course, has sort of a decentralized structure as of now, so it was really important that we're able to form a very consolidated unit. And this involved a lot of very sort of administrative and frankly difficult work, including getting a tax ID for our organization, working with the IRS, all things that I had absolutely no knowledge of before this year, and it's still definitely in the process, but not something to underestimate. The third process was to make sure that Athena could contract with Blue Shield as a provider, so that we could submit claims to them and they would recognize that these services were part of the Wisdom trial and that would successfully translate to a reimbursement being shuttled back to Athena. And lastly, and this is a process that we're still working on today, is a sustainable and innovative billing workflow that would allow Athena, again, to receive these services directly back to us as opposed to the medical centers under which Athena is housed. And furthermore, to sort of reinvent what a billing workflow typically looks like, to make sure that we can minimize the overhead and pre-authorization costs generally associated with submitting large numbers of bills. So in terms of next steps, so we've done a lot of work with Blue Shield, and we're well on our way to having them sort of open with us when our trial begins in November. But the next step is really to take this CED approach that we've used with Blue Shield and apply it to a majority of other health plans that we are currently in conversation with. And something I wanted to highlight is that a lot of organizations, as I mentioned before, don't have a formal CED policy written. And we either want to encourage them to start writing a new policy, or in the case of a few of our partners that we've been working with, figure out a short-term alternative to CED. That is, in the first few years, perhaps find an alternate source of funding for that specific investigational service, but then ultimately encourage them to use the data collected in that initial trial period to start implementing a CED policy for that investigational genomic test. Another thing that we're hoping to count on is Athena has recently learned that we will be publicized at Dreamforce, which is a huge conference that Salesforce puts on every year. We're being highlighted as a precision medicine initiative, and this screencast will ultimately be seen by perhaps more than 1 million women. So it'll be very interesting to see, following that level of publicity, if there are women interested in this trial, if they can put pressure on their insurance representatives to make this a covered service for them. As I mentioned before, we still need to negotiate the final reimbursement rates for each of those services. Test the billing workflow that we've put together with a very interdisciplinary team. People who work in claims, people who work for Salesforce and other technology platforms that we've been working with, and making sure that the money that we are sort of putting through these claims actually comes back to Athena. That's the most crucial point. And lastly, and this is also very important, to share our success implementing this new sort of reinvented CED model with both the payer community and the clinical trial world, so that people understand that we can use this sort of innovative policy that was first started in the 90s but hasn't really been implemented until very recently for similar clinical trials. And a big thank you to everyone here for helping work on this project with me and sort of answering all the questions that I had along the way. As I mentioned before, I had absolutely no experience with insurance or billing whatsoever, and I've learned a little bit more than I might have liked, but ultimately it's been a very rewarding experience, so thank you.
Who knew that insurance could actually be interesting? There you go. So you didn't say what was the most important thing that you learned this year.
What's that?
Most important thing you learned this year?
Oh, I did not. Okay, well, all right, let me just pass this off to Marie.
All right, and questions, be thinking of questions while you're waiting.
Yes, sorry for forgetting. I think the most important thing, so as I mentioned, Athena is a cross-site collaboration, and for us that means that a lot of the work that we do is over phone. And a lot of the people that I talked to for the course of several months working on this project, I hadn't even seen in person until our first Athena retreat. And it really sort of highlighted the importance to have clear communication with people that you might not interact on a day-to-day basis. And also that despite our efforts to centralize Athena and make it as seamless as possible, it's also incredibly important to recognize sort of the variation and the innovation that happens at each of the sites. And this was my first time working on a multi-site collaboration, and it was a challenging process sometimes, but ultimately something that is incredibly important for any sort of collaboration in the future. So I did appreciate that.
That's great.
Yes.
Okay.
All right. Questions?
Thank you. Any other questions for Priyanka? Is that manuscript written?
That's work in progress. That's the last next step.
Okay, this weekend. Yes. All right. Okay, perfect.
All right.
Thank you, Priya.
Thank you.
All right. Hi, everyone. My name is Avi. I'm one of the Breast Care Center's interns in radiation oncology, and one of the things I learned this year was...
You need to put the mic higher.
Oh. How's this?
Better.
All right. So I'm one of the interns in radiation oncology here. One of the things I learned this year is patients can really tell when you care, whether that's the time you put into a conversation, the effort, or the energy you bring to that conversation on the phone or in person. And I learned that from the doctors that I've worked with here. So today I'll be presenting something that we've been working on all year, and that's a handbook for skincare and radiation oncology. So first I'm going to go over some background, how these reactions actually occur and what radiation is to a patient. Then I'll go over our skincare recommendations and the treatment protocol that we put our patients on. And lastly, I'll go over our conclusions and why this is clinically important and significant. So first, as some background, in 2015 it was estimated that about 1.6 million individuals will get a diagnosis of cancer. And of those, about 50% will receive radiation. Of those same 50%, 95% are going to develop a side effect called acute radiation dermatitis. So that leaves us with about 760,000 people that are going to have to face the challenges of this side effect. So what is radiation therapy? If you look at the image right here, this is the UCSF CyberKnife machine. So how this works is electrons are accelerated through the linear accelerator. They hit a piece of tungsten metal at the top, they excite electrons, those jump to a higher orbital level, they drop down and you release photons which target the tumor cells. So the image right here is, specifically for this machine, how it works is that it rotates around the patient and delivers radiation to the tumor from different angles. So that's what you're seeing in this image right here. And eventually it causes double-stranded breaks in the cancer cell's DNA. And that's what causes these cancer cells to die.
Attention, please.
Well, what happens to the normal tissue? You actually also cause alterations in the normal tissue as well. So what does that cause? Well, that causes acute radiation dermatitis. So from a pathological standpoint, what you're looking at right here is the epidermis, and it's blown up over here. So what happens is the radiation and the photons travel through the epidermis and mainly damage the basal level stem cells at the bottom of the epidermis layer, and that causes them to reduce the rates of division, so they can't adequately replace the cells on top that are shedding off, and this causes the skin to rift open. So why do we need a handbook? Well, 4 reasons mainly. There's a huge diversity of reactions and each patient is going to vary in these reactions by their own factors and also treatment-related factors as well. We've noticed that ethnicity causes these reactions to be different, smoking status, BMI, and the area or disease site itself. There's limited data on this topic as well. Most of the data focuses predominantly on breast cancer. Researchers have been using different endpoints to determine when skin is actually healed, and they also have different scoring rubrics to quantify the toxicity as well. There's a lack of awareness in the community. Oftentimes these reactions peak far later, typically in the last week of treatment, when patients are sent home and don't have follow-ups, so they have to face these challenges themselves. And patient quality of life is a huge issue as well. If we can have proper skin care, we can prevent breaks in treatment and have these skin reactions actually properly healed. So now I'm going to go over some of our skincare recommendations. The next images are more graphic, but I'm going to go over sort of the natural progression of reactions that we do see, and then I'm going to present 3 different patient cases. So one's a breast cancer patient, one's an anal cancer patient, and one's a head and neck cancer patient. So these are different types of acute radiation reactions. The images on the left, first what you typically see by weeks 2 or 3 of treatment is something called erythema. This is a natural inflammatory response and a dilation of blood vessels. So on the top, you see a bilateral breast cancer patient with some light red on both breasts, and on the bottom you see a moderate form of erythema, which is the redness progressing and becoming a little bit more red. On the top image, you see something called hyperpigmentation. This usually accompanies erythema. It's darkening of the skin, and we typically see this in darker skinned individuals like African Americans. This lady is actually an Indian lady. On the bottom, you see dry desquamation. This is dead skin peeling off and being replaced by new skin underneath. And often it can come before or after what we call moist desquamation. So this is actually the skin rifting open, and what you're seeing now is raw underlying tissue. This is a head and neck cancer patient right here, and you can see some exudate coming out of his neck. And this is a 12-year-old Ewing sarcoma patient. And you can see new skin islands forming to heal the skin here. So this is our first case for the day. This is a 48-year-old Filipino stage 2 breast cancer patient, post-breast conserving surgery, and she received external beam radiation, which is typical for our breast cancer patients here. So how we did this is that we tracked this patient at each week in her treatment journey here, so over the course of 6 weeks till she finished treatment, and we took a photo each time. And this patient in particular was placed on our skin regimen, and the skin regimen has a twofold goal. The first goal is prevention, the second goal is intervention. So what we did, if you look at the first 2 weeks here, there's no real reaction. So our goal here is to moisturize and hopefully prevent something from happening, and if it does happen, minimize those side effects as much as possible. So what we did is use a light moisturizer called Lotion Soft. This is essentially, it's a thin lotion and acts as an occlusive agent to help maintain moisture in the skin. By the time you get to week 3 and week 4, you can see a reddening in the inframammary fold, particularly right here, called erythema. And so in week 3, we added calendula. Calendula is, it's essentially a thicker cream that helps maintain moisture, and it's derived from the pot marigold flowers, it's from those orange flowers. And you want to usually apply this to intact skin before the moist desquamation occurs. So again, you see that here. So by week 5, you can see right here that the patient's skin did rip open. You've seen some areas of moist and dry desquamation. So we switched the protocol a little bit more now. So what we added was something called A&D ointment. A&D ointment is composed of a humectant and also an occlusive agent. So it's what happens is that it promotes absorption of water from the dermis into the epidermis to help maintain moisture in that skin, and also prevents evaporation from the skin into the air. Then we added Skintegrity. Skintegrity is another spray or a cleanser that we use. It's responsible for removing necrotic tissue that might develop, any buildup, bacteria, proteins. And we added this. So this is called Mepilex AG. So the latest data has shown that silver ions are known to bind to bacterial walls and bacteria that could develop in these areas and actually destroy them. So it's actually antimicrobial as well to help prevent infection. So the take home here is that by the time they get to 2 weeks post-radiation, the patient has healed better than the national average and what we typically see in the eyes of radiation oncologists. So, and we're hoping that our protocol can continue doing this for people. The next case is a 27-year-old HIV-positive anal cancer patient. So, and again, this is an African-American male. I want to emphasize that too because these reactions vary tremendously across ethnic type as well, and we've noticed that. So this person also had concurrent chemotherapy, and chemotherapy can also play a role in changing how a patient may react as well. So in the first week, you see just some slight reddening, but mainly by week 4 and 5, you see the moist desquamation occurring in the perineum and around the anus. So what we did is we kept them on the same sort of creams, A&D and calendula, but we added something new, and that's called Hibiclens. So for these patients, we have them sit in a sitz bath. It's essentially a pail of water with diluted Hibiclens inside of it, and they can sit inside of it, because it's hard for us to treat those areas otherwise. This patient actually had to have a break in their treatment because the reaction got pretty bad, but what we did is we added lidocaine for pain, and we continued them on the same 4, A&D, calendula, and Hibiclens. I'd like to direct your attention to these 2 photos right here. This is the 2nd week of his 2-week break, and this is his last week of radiation treatment. And you can see the skin has gotten lighter here, and this is something we typically see for darker skinned individuals again. So we can see hyperpigmentation, which is a darkening of the skin. We can also see something called hypopigmentation, which is essentially the loss of pigment. And this is occurring because sometimes the melanocytes from radiation are altered as well. So again, we used a silver lining pad to promote healing. And we actually just saw this patient recently. This is him 2 months post-radiation. We have another photo where we just saw him. And he's actually, he looks even better than this. But the point is, from here to here, there has been optimal healing. And our last case is a 69-year-old Caucasian invasive tongue cancer patient. This patient also had Mets to his nodes. And he had intensity modulated radiation over 6 weeks and concurrent cisplatin. This patient did pretty well for a normal head and neck cancer patient. In contrast to breast cancer, we start immediately with calendula rather than lotion soft. By the time you get to week 4 and 5, you can see some erythema developing to a more greater extent. Head and neck cancer patients can also have some itching in their neck sites right here, so we put them on hydrocortisone. And by the time you get to 1 week post-radiation, which is typical, that's when it should peak, you see some moist desquamation occurring in that neck fold right there. And that's when we switch to Hibiclens and we put those dressings. So typically before the skin rips open, we want to moisturize, and when it does, we want to add these dressings to promote the most optimal form of healing. And this is him 4 months post-radiation, and he looks a lot better. So just for the conclusions here are, why is this clinically important? So it's the first book published with data-driven protocols for addressing radiation dermatitis, and we want to promote awareness that this is a treatable side effect. Our protocols can allow these patients to heal better and faster over time. And as you've noticed from the photos I've shown you, there's an extreme diversity of these reactions in general, so it's important that we were able to cover these reactions across cancer types. We have everything from breast, head and neck, GU, CNS, to different ethnicities, radiation techniques that may differ from each other in their beam energy, their field overlapping. And we've aggregated the data, even though it is limited. We put that all into one place for people to read about. And I think the most important thing is that it can improve clinical practice in the sense that if we can have proper skin care for our patients, we can avoid those breaks in treatment. And if we avoid those breaks in treatment, we can reduce the chance that these recurrence risks will increase. So our future directions is we're trying to publish this handbook by the end of July, and we're right on track. We've already submitted about 4 chapters. And we're showcasing this handbook at Astro in 2015 in October. And the last goal, I think Patrick may be working on this, or the department as well. We're going to create new patient manuals for at-home skincare. So this handbook is specifically meant for clinicians and the nurses that work with these patients, but we want to also create a manual for patients to take home and inform them and educate them on how they can take care of their skin as well. Acknowledgements, thank you Dr. Falvo, Dr. Park, Florence, and Keith. They were my core team in radiation oncology, and they're here today. Thank you for coming in. Dr. Esserman, obviously, for putting the entire program together, and Meredith. Jeff and Shelley for teaching us how to interact with patients in the best way possible. And then my fellow interns, thank you so much. Yeah.
So I have a question. So you mentioned that these are data-driven protocols, and so I presume you have data on, you know, the amount of healing. Could you, number one, give us a sense for how much time you think you take off the healing process with this approach, and sort of what you're doing? Are you imagining that that patients can track their? Are you having patients keep diaries at home? Is that part of the protocol to try and understand, to get continuous feedback about skin healing?
Right, so there has, I mean, one of the most important studies that's been published so far is the contrast, the negative use of aloe vera. So patients generally go out and buy their own products outside and don't use the creams that we provide. And one clear example of this is we had a 12-year-old Ewing sarcoma patient, and Vaseline was applied to the skin. Vaseline doesn't really promote the healing, according to the latest data, and the reaction got worse. We actually sent our team over there and put the patient on our regimen, and the patient healed within 4 or 5 days in a drastic amount. So, in regards to your second question about patients keeping a diary about it.
So how do you know? I mean, to be able to, do you have a way of being able to track?
Right now, we don't have a way to see whether they're doing it themselves at home. All we can do is tell them, you know, these are the creams you can use.
Get an apple out.
Well, I mean, we see them every week, so in contrast to a lot of other services, we see them every week, we check them. I think one of the major things for this is that many radiation oncology departments pay no attention to skincare. Patient finishes, and then they come back 6 weeks later. In that period of time, they've had these horrible skin reactions, don't know what to do with them. And also with the web, there are many products that are being promoted that are of no value whatsoever, but cost a lot of money. So we're trying to educate patients as to what they should use. But what's even better at UCSF is we provide all the products at no cost to the patient, including some of these very expensive dressings where it's $100 a sheet. So we do all of this for the patient.
That's great. You guys use Medi Honey?
Mm-hmm.
We do.
We do.
Oh, that's right. That's where we go and steal it together. All right. That's good. Thank you so much.
So this is my second year at the BCC. I'm on my way out. And, and so I think the most important lesson that I've learned over these past 2 years is to get comfortable with the uncomfortable. I think as an intern, you're going to be in a lot of uncomfortable situations with doctors or patients, whatever it is. We definitely get thrown out there with very little experience, and we learn on the fly. But get comfortable with it, because it's always a good learning experience, and some of the most profound moments you'll have is in those uncomfortable situations. So today I'm going to be talking about the low-risk registry, and I'll kind of go over the background of it and why we are interested in this patient population. And then I'll talk about some of the preliminary results we have for the study. And then after that, I'll talk about why it matters and where we go from here. So the low-risk registry study, we pull patients who have screened for I-SPY2 and have this specific ER-positive, HER2-negative nanoprint low-risk signature. Since they're not eligible for the treatment phase for the I-SPY2 study, we put them on this registry study. We don't dictate what type of treatment they need to receive, so they're free to choose whatever recommended treatment option they decide between them and their physician. And we are basically here to just track what they do and see what their outcomes are, so that we can learn a little bit more about this type of breast cancer. So the main objectives of the study is to really learn about the treatment patterns for these patients. What treatment options are they choosing, and how does this turn out for them? And we do this over a 15-year period. At the same time, we're collecting some tumor specimens from them so that we can run some tests on their biomarkers and see if there's something different about their tumor. And we're collecting some MRI data as well so that we can look at all of this together in conjunction with their disease. So the way that the study works is you have this patient who is screening for I-SPY2. They turn out to be mammogram low risk, ER positive, HER2 negative. We consent them for the study, and then they go on and do whatever treatment they decide with their physician. It can be surgery, neoadjuvant chemo, or neoadjuvant hormone therapy. These are usually the three options. And then for the ones that have neoadjuvant therapy, they go on and have surgery, and we just follow them for 15 years. So it's very simple for the patient, really not much that they have to commit to. We do all the work on the back end. So hopefully, as we've seen, patients are pretty willing to do this study. So far, we've enrolled 98 patients nationwide at 16 different sites. We still have a lot of work to do because we have 62 patients who are eligible but haven't been consented at the other sites. At UCSF, we've been doing a pretty good job. We've got most of our patients. We still have 6 more that we can consent, but we've consented 44 to this point. So as you can see, UCSF is actually kind of the bulk of the data that's coming from this study. So far, the patients that we've seen are coming in are pretty young. The majority of them are under the age of 50, and the majority of them are premenopausal. And so this is important because, especially for younger patients, we're really interested in reducing their risk of recurrence because they have so much longer in their life that they might have a recurrence. After that, we see that a lot of these patients are coming in with advanced disease. You can see in the tables, the T size, typically they're T2 or T3. A lot of them come in with node-positive disease, about half, and the majority of them have intermediate grade or higher tumors. And so this really highlights the fact that they're coming in with advanced disease, but they have this low-risk signature, so there's a dilemma here. Ultimately, you can see the breakdown of what treatment options they choose with their physicians. So I'll go into the details of kind of each individual treatment arm. So for the upfront surgery patients, which is about 22 out of 86, well, a lot of these patients are coming in with node-negative disease. Then they go to surgery and we find out they actually have node-positive disease. We're not thinking that the disease is growing during this time, but it's kind of highlighting the fact that we're probably underestimating the extent of their disease to begin with. As you can see, a lot of them actually have a lot of positive nodes, so it's not just 1 or 2. Some of them have 18 or 6. So this is kind of highlighting the importance that a lot of these patients have a lot of disease to begin with. So for the neoadjuvant chemotherapy patients, we had about 41% of them go through this. None of them had a PCR, which is kind of surprising, but at the same time, we probably would have expected this since they haven't shown a lot of good response to chemotherapy. PCR is pathologic complete response, so a lot of them already still have, even though they go through 6 months of chemo, they still have a lot of residual disease at the time of surgery. And so we're starting to, as you know, in I-SPY2, PCR is really important to us because that's how we determine one of the early markers of whether a patient will do well and have a good prognosis or not. So for these patients, it doesn't seem like chemotherapy is working that well for them. For the hormone therapy patients, still almost half of them have to have chemotherapy afterwards. A lot of them, just like the upfront surgery patients, are still having node-positive disease at the time of surgery, even though some of them didn't have node-positive disease to begin with. So really, what this is showing us is that hormone therapy might not be sufficient if it's just on its own. So we need other options, and if chemotherapy also isn't working that well, then we really need to start looking elsewhere. So in summary, we have treatment data for 79 patients for neoadjuvant and adjuvant treatment data. And 64 of these patients out of the 79 still went on to receive chemotherapy at some point. So despite the fact that they're mammogram low risk, they're still getting chemo. There's no consensus on what's the best way to treat these patients. And it doesn't seem like they're having even a good response to the chemotherapy. So we're really starting to look and see what we can do about this. So to kind of conclude and summarize the main points, most of these patients are young. They have advanced node-positive disease, but they're still getting chemotherapy, and this, despite the fact that we know it's probably not working that well for them. And the reason for this is that the clinicians are facing a dilemma. They're uncomfortable with foregoing chemotherapy if they see a patient have surgery with node-positive disease, an extensive disease, where kind of the only option is to give chemotherapy. So really, this study we're really trying to learn more about what it is that's driving this disease and why is it that they're not responding that well to chemotherapy and what we can do about it. So for the next steps, we want to continue consenting patients and get more data because we have a lot of patients within this cohort that we can learn from. We can continue analyzing the biomarker data that we have and figure out if there's something in their genome or something that we can find in their tissue that's driving some of this discordance between clinical risk and molecular risk. And lastly, there's a potential that we could start a new pilot study that tests endoxifen, which is a new drug, and see if maybe this would help a subset of the patients who are not responding that well to the treatment that we have available for them. And so, just want to thank everyone for helping me with this project, especially Dr. Chan, Mamta, have been incredibly helpful, all of the I-SPY2 CRCs nationwide, sending us all the data, and everyone else for making the last 2 years pretty amazing.
So I have a question for you. So Richard, you know, one of the reasons why we try and do neoadjuvant therapy or to give the chemotherapy or whatever, hormone therapy first, so we can see how it works. So what do you think, you know, and I think as you pointed out, things don't seem to be working terribly well in this situation. So what do you think one of the most powerful impacts that observation can have?
I think if it's not working and it's not giving them benefit, then especially with chemotherapy, we're exposing them to a lot of unnecessary toxicity. We're giving them side effects, and if this is impacting their quality of life but not really helping them in terms of their recurrence risk, then maybe we need to start thinking about other options and not giving this to them unnecessarily.
Right. So I think it's interesting because you mentioned at the beginning about don't be afraid to put yourself in an uncomfortable situation. So sometimes people prefer to give adjuvant therapy because then you don't have to see whether, I mean, you can give it and hope that it works and then it doesn't have to be in your face whether it's working or not working. And now we don't have perfect endpoints here, but part of this is trying to expose where our treatments are not so good, making us uncomfortable, and hopefully uncomfortable enough to be courageous enough to make change, right? So that's everyone gets afraid to let go of things because they might work. But sometimes you have to let go of some things to try something new, right? Mm-hmm. So we hope by the time you come back for the intern reunion next year, we'll have 2 treatment pilots, right, Jeff?
Exactly.
Yeah. Okay.
Wait, I have a question.
Yes, great.
A layperson question.
Yeah.
So is it the particular diagnosis, like is it the biology that makes it difficult to treat, or is it because there's just no drugs that are tailored to that? Like is there research on that? I'm just curious out of that particular, or is it a longer question than we have time for?
I don't know exactly what is driving the fact that they're not responding to the treatment. I assume
That's what the biomarker studies
yeah,
are
it's
for.
probably
I mean,
biomarkers.
it's the $100 million question. As we get better at treating triple-negative cancer, HER2-positive cancer, because we have more targets to go after, one of the big dilemmas that's left over is, you know, hormone-positive tumors that aren't really being driven by cell turnover or proliferation. You know, chemotherapy is pretty targeted to cell proliferation, and a lot of the signaling pathways are targeted to that. We don't really understand what's driving it. Would you say that's fair, Joe?
I think that's very fair. I think that I think if people are uncomfortable not giving the most aggressive therapy to these young women who have a lot of disease, but I think we're often treating ourselves, and we don't have any other options for them. And it's not that they don't get any benefit. It's possible that they get, you know, a few percentage benefit, but with the amount of toxicity that you expose them to, it's just not necessarily worthwhile. So I think we need to just change complete strategies. You know, the hormone therapy is important, but it's not going to be enough. The chemo is unnecessarily toxic. I think we need to think about whether it's immunotherapies or, you know, T-VEC, oncolytic viruses, completely think outside the box.
But the problem is past CR isn't a good surrogate for outcome in these low-risk patients.
But you don't know
CR
if
doesn't impact on survival.
Well, okay, but you don't know.
And you don't know that they haven't responded, because they can respond but not completely go away. And so,
Yeah, so what do you, that was sort of what my question would be, what do you think is a good marker of response?
Well, that's been the limiting factor in research for this population because we don't have a validated biomarker for response. I mean, we know that if you do, in this group, if you do have a PCR, they do better than if you don't, but so few get a PCR. Just because you don't get a PCR doesn't mean you will do poorly, but we do know if you have 16 positive nodes, you have risk.
These aren't no-risk patients. They just happen to be maybe low early risk, but, you know, this is risk, for sure, high-risk patients. It's just that they'll continue over the 10 years. The risk is very high.
Right, so I think one thing is finding better treatments, but it's also moving away from maybe giving chemotherapy reflexively because we think that because of their risk, they may not be benefiting proportionately.
But some of the things we're doing is, again, that's part of the reason why we're trying to figure out what the biomarker panel is. And there are two ways to think about MR imaging. And one of the things we know is this is looking at the stromal uptake, you know, so you can get enhancement in the tumor itself or in the tissue surrounding it. So looking at stromal reaction. So we fortunately have all the MR data in diffusion. So we're trying to, and that's particularly what Dougie has pushed us to really look at another imaging biomarker. So we have, but again, you can't make it a primary endpoint because we haven't had a chance to prove it. That reminds me, we have to work on that. But the, but you know, Ki-67 has been, you know, this business of maintaining low proliferation, but we don't really think that's a great biomarker either. It's Matt Ellis has sort of made it the gold standard. So that's part of the challenge, right? So it's trying to come up with measures that we can look at. But I don't think that you want to preclude the opportunity that you could see a significant change in what happens to the tumor. If you have the right treatment, you know, we see, and actually older women, you know, who come in with these lower risk tumors and big, lower molecular risk tumors, big tumors, you put them on hormone therapy and those tumors can absolutely melt away. And by the way, those people do just fine. So I don't think we should take that off the table. We just haven't found things that work, and that's the truth, but we have to work harder at it. Okay.
Hi, I'm Rebecca. So I think my biggest lesson this year was just really about the power of bearing witness to patient experiences of pain, stress, and really their individual narratives of living with serious illness. That was just an incredible lesson to me. So today I'm going to be focusing on advanced breast cancer and specifically my work with the Advanced Breast Cancer, or ABC, program. I'd like to start my presentation by looking at some statistics about end-of-life care. So the majority of people would prefer a natural death if they were to become seriously ill, rather than have all possible treatment available. And the majority also worry about being a burden to their family when it comes to decision-making. Despite these clear preferences, only 7% of people have actually spoken with a doctor about their end-of-life wishes, and 56% have not communicated their wishes to loved ones. And finally, while 70% would prefer to die at home, only 32% of deaths actually occur at home. So there's a clear gap between patient preferences and what is actually happening at the end of life. And advanced care planning is a way to bridge this gap. Advanced care planning refers to the ongoing process of identifying patient goals and values for care at the end of life, even when they may not be able to speak for themselves. And these wishes are recorded in documents called advanced directives, which are legal documents that, in addition to specifying patient preferences, also actually designate a surrogate decision maker. That patient is unable to speak themselves. And that is called the Durable Power for Healthcare Attorney, or DPOH. And advanced care planning processes reduce under or over treatment relative to patient wishes. They also help them avoid unwanted outcomes, which is, I went over before, often invasive treatments that don't address patient goals, a burden on family, and dying in the hospital. Additionally, advanced care planning processes are associated with improved mental health care outcomes for caregivers and loved ones. So at the UCSF Breast Care Center, these conversations are usually started by medical oncology perhaps social work, or the symptom management service, pictured below. So the symptom management service is an outpatient palliative care consultation service here at UCSF that myself and with the help of a lot of oncologists in the BCC, we've worked on collaborating more closely with this year. And palliative care is focused on providing patients with relief from the pain, stress, emotional burden of dealing with a serious illness. And it's really focused on improving quality of life, not only for the patient themselves, but also for their family. And it's important to note that palliative care can in fact be provided at any stage of a serious illness, and it's actually shown to have benefit if it's provided earlier on in a terminal diagnosis, because it's frequently misconstrued as end-of-life care. So at UCSF in APEX, this is how advanced care planning is documented. You see up here up top, there's a banner where a scanned advance directive is visible if you click on it. And then here we, in the problem list, alongside all the other medical problems that this person is facing, you have notation about advanced care planning. And when you click on this, it opens up to a physician note about the discussion they've had. For example, it might have a note about who they want to make decisions for themselves, perhaps if they want to be resuscitated or not. And this right here is sort of the snapshot, what you see when you open up a patient chart in APEX. So it's really able to be viewed at first glance. So what are statistics about advanced care planning for the advanced or metastatic breast cancer patient population here at UCSF? So my predecessor, Jenna, did a chart review in May 2014 that showed that approximately out of 254 total patients with metastatic or breast cancer, MBC for short, at UCSF, only 37 or 15% actually had some form of advanced care planning documented in the problem list, which is pretty low. So the Advanced Breast Cancer ABC program was an effort that's been continued on for several years, and several of my predecessors, really to address the unmet needs of MBC patients as a result of living with incurable disease. And of course, one of these is lack of advanced care planning. And to address this, we've worked on embedding a palliative care physician who works with the symptom management service, Dr. Rabo. He's the director, 2 half days in the breast oncology clinic, really to work alongside oncology and collaborate closely with them to provide the best care to patients dealing with metastatic disease. And so of course he helps manage symptoms, but a large part of what he's also done is helped with these issues of advanced care planning. So early results of advanced care planning with our embedded palliative care program since starting in October 2014 is that we've had 35 patients who have had 2 or more visits to the symptom management service. And on the second visit, the standard is that the palliative care physician will initiate a discussion about advanced care planning. Usually it's not the first thing that you bring up when you meet someone. So of the 35 people who have had 2 or more visits to the symptom management service, 13 or 37% have advanced directives scanned into the electronic medical record. And 30 or 86% have advanced care planning discussion noted in the problem list. And this is a significant improvement from the 15% that Jenna estimated back in May 2014. So while we've been able to have relative success with having these discussions, you might imagine that they are not without barriers. People frequently have a lot of trouble addressing end of life and thinking about mortality. And to illustrate these barriers, I'd like to offer a patient narrative. So Miss O is a woman with metastatic breast cancer who's seen Dr. Rabo in symptom management a few times. Her pain is now pretty well controlled, and she's able to accomplish her activities of daily living, and she's feeling pretty good. And when asked for updates on her advanced care planning and advanced directive, she turned to Dr. Rabo and she said, "But no one wants to talk about this stuff. I mean, do you have one? Do you?" Asking me, who is sitting in the appointment as well. And I think it would be such a powerful statement if we were able to turn to our patients and say that, yes, we do have advanced directives because we too are thinking about them. we present this to patients as a routine, responsible part of their care, so perhaps we should be taking our own medicine with regards to advanced care planning. So on this sort of environmental approach and encouraging clinician and staff completion of advanced directives, we started thinking about how to get this going. So initially, we thought about maybe having an advanced directive signing effort within the breast care center, and then advertising this information to patients, seeing what they thought. We encountered some barriers about this perhaps being coercive or violating privacy, so we decided to rethink things a bit. And now I'm engaged in working on sort of a more social media approach that starts from the symptom management service, who are frequently the people who are initiating these advanced care planning discussions. We're calling it the Honor My Wishes campaign. So through use of social media, you can check out the Symptom Management's Twitter. We've asked clinicians and staff at UCSF to take a picture with just the front page of their completed advanced directive, so no personal information, along with a personal reason for completing their advanced directives, and then to hashtag it with Honor My Wishes to identify this campaign, their department, and then their roles, so we know who are the people who are filling these out, really to just personalize this effort. And we've asked people to either tweet it themselves, knowing that some people like to tweet, or just email us and we will post it for them. So I now have some examples of the photos that we've received. So here is mine. This is Camille Borgo, who works with Hospice by the Bay, and her reason is because I'm the boss of me. This is an attending in the symptom management service, Dr. Kelton. This is Gail Kojimoto, who's the program coordinator of the symptom management service. This is a medical student at UCSF. And this is Dr. Rabo, who's the embedded palliative care physician. And his reason is because it's later than you think to start thinking about these issues. This is a psychologist who works at UCSF. Why not? And here's Mamta, my coworker, who also completed her advanced directive. And finally, a resident at UCSF who says, I filled out my 5 wishes, which is one of the many advanced directives that are available, so that my family doesn't have to worry about what I would want. So next steps. I am going to be continuing on as a second-year intern, so I hope to continue working on this Honor My Wishes campaign, partnering with a palliative care and geriatrics blog called GeriPal, which was started by 2 faculty at UCSF, but has national readership. So it'd be a good way to sort of advertise this effort to people. Also, perhaps expand this to the whole cancer center, perhaps by email distribution, use of UCSF websites, advertising at meetings. And then, very importantly, we want to look at the patient response to this kind of initiative. Does seeing this information increase patient participation in advanced care planning? Does it help start any sort of conversations? So I'd like to conclude my presentation today with a quote from a recent New York Times article. To the small extent that we have any choice in this uncertain life, it is wise to face your own death. In a world where so many of our fellow human beings live with threats of terror and destruction, if you are lucky enough to imagine you might have any measure of control over how you die, that is a privilege that should not go to waste. So thank you for your attention today. A special, huge thank you to Jeff and Shelley for being my mentors, my support, guidance this year. To Mike Rabo and Gail Kojimoto at the Symptom Management Service, and to really all of the oncology attendings, Dr. Rugo, Dr. Chen, Dr. Melisco, and Melanie Meager as a fellow, for all their help and support with ABC. And of course, the patients and families I worked with. It was an honor to learn from them, and I think in this kind of work, patients are often our best teachers. Thank you.
So, okay, question from now?
Yes. So how many varieties of advanced care directives? I mean, is there a standard, or does each hospital have different, does each insurance plan? Like, how many versions?
So there's a variety. UCSF actually has its own, which is available online. You can download a PDF. The 5 wishes, which a couple of us filled out, is made by sort of a separate company. So there really are a lot of varieties. The state of California has their own as well. But the important thing to note is that they are all legally valid if they're witnessed properly.
And do, and do all states have them?
Mm-hmm.
Okay.
Yep.
If you have ones that may not be in your UC medical record, what are the chances anyone's going to find out about that and follow it?
Right, so that's actually one of the barriers to ensuring that patient wishes for end-of-life care are followed. The fact that advance directives are often not visible to the medical provider. So actually, it's been found that the conversations about advanced care planning are actually more effective in changing end-of-life outcomes versus just completing a document. So the reason why I showed that Apex picture is that with the ABC program, we're making a big effort to make sure that if a patient has an advance directive, it's in the medical record, or there's some notation in the problem list. And that notation in the problem list may not be a formal advance directive, but it's still useful and actionable information to clinicians.
So I wanted to also bring up, you know, in light of what Prihatha presented this morning around coverage with evidence development, you know, one of the barriers to, so two-part question. I'll come back to the coverage with evidence development in a minute. But so what do you think the impact has been of having the embedded physician in the practice, and is that something you think you can quantify?
Well, we're actually, so let's see, just observationally, because you know, it's a fairly new program. We started in October. I think it's just presented kind of a united team to patients, which is really important between palliative care and oncology. Because I think patients, and frankly, I guess the world at large has an idea that sort of palliative care and thinking about end-of-life issues is sort of synonymous with perhaps giving up, or and I think that the fact that we're able to present collaboration in oncology and palliative care side by side is a really powerful statement to patients. And I think that looking forward, we hope to look at end-of-life outcomes, so chemotherapy received in the last 30 days of life, ICU stays, hospital stays, once we have more patients who have passed through the program and who have passed away.
But you have at least the beginning at that metric of the 15% to 86%. Right. So one of the barriers, obviously, we funded the change.
Right.
Right? So this is, when we get back to what Prihatha presented this morning was, this is about how you take the money that's in the system and repurpose it. Every insurance company knows that perhaps the most money is spent in the last 6 months of life, right? And they all know that everybody knows that's not a good thing, and everyone feels somewhat powerless to change it. This, of course, is an opportunity to change it. So if you were going to do you believe that you're collecting the right kind of data that would allow you to make a pitch about coverage with evidence development to guess who? And who would we pick? Who would we think would be the most opportune insurer? CMS or?
Medicare.
Well, there's actually
since Marcus Thagison is particularly interested in end-of-life issues, right?
Well, there's a really exciting decision this week that now physicians are going to be reimbursed for advanced care planning discussions through Medicare. So I think that, yes, we're collecting also various survey data related to patient satisfaction, kind of general satisfaction with quality of life and how they're coping with their illness. So we have sort of patient-reported measures in addition to symptom burden, and I think that tracking through use of the medical record, hospitalization usage, chemo usage, and hospice use, I think will be a really powerful statement. Right. We just don't have it right now.
So I have another little project to add to your year 2. So I want you to go back and look at, so Prihatha, go through sort of this framework that we have for coverage with evidence development. Why don't you start thinking about 3 CPT codes or 4 things that you think is a coverage with evidence development program that will actually make this whole program sustainable. And then and it's something actually that UCOP is, the 5UC, the University of the President, the Office of the President is very interested in. So, okay. Great.
Okay, my name is Tessa, and I'm also, like Richard, finishing the end of my 2nd year here in the internship program. I've worked for the past few years as a clinical research coordinator for the I-SPY 2 trial. And the most important thing I've learned, this is something I think Laura talked about a little bit last night, is to ask questions when you don't know and find the people around you who are going to be able to help support you, and both with logistical concerns, medical questions. When you're working with patients, you don't want to risk pretending you know something that you don't. So that's something I learned in the past 2 years. All right, so for my final presentation this year, I sort of embarked on a separate project that I typically work on in my day-to-day. I wanted to look at one of the unique needs and concerns that young women with breast cancer face. So we know that 15 to 20% of breast cancer diagnoses are in premenopausal patients, premenopausal women. 7% of cases are diagnosed under the age of 40. And in these cases under 40, 2/3 present with stage 2 or higher breast cancer. So the young women tend to have later stage and more aggressive breast cancers than the average, all breast cancer cases as a whole. And young women with breast cancer face a variety of unique concerns, both physical and emotional and psychosocial. And the one that I'm going to focus on today is the possibility that they become infertile after the treatments that they have for their breast cancer. In the United States and other developed countries, many women are delaying pregnancy until their late 30s or early 40s. And so by the time a woman presents with breast cancer at this age, she may not have yet completed her family and had the number of children she wants to have. And we know there's a lot of data to show that fertility concerns are an important one for young women with breast cancer, and one that is unmet. So 50% in this study from Dana-Farber, 50% of patients felt that their concerns about infertility were inadequately addressed. So what are some of the barriers to addressing this, both from whether they be real or perceived, and of course there's some amount of research looking into whether these are real or perceived barriers. So providers and patients are worried about the cost of fertility preservation processes, concerned about the safety of these techniques and the safety of becoming pregnant after a diagnosis with breast cancer and treatment for breast cancer. And there are concerns about possible delays to starting treatment by going through the process of preserving fertility. In particular, this is a concern for patients who are about to undergo neoadjuvant chemotherapy because they have large tumors and oftentimes positive nodes, and we're not going to surgically remove the tumors or the nodes until after they've gone through a number of months of treatment. So there are particular concerns about kind of moving quickly and getting started on the treatment they need. So Dr. Chen and I decided to use the I-SPY 2 patient population as a nice sort of sample population to look at. Within the context of a clinical trial, the patients are a bit more uniform in terms of their characteristics, and they're all being recommended for the same treatment regimen. So it gives us a nice group to compare things within. So we embarked on a detailed retrospective chart review with CHR approval for this. This study didn't involve any patient contacts. We were just looking in their medical records. And we asked Dr. Mitch Rosen, who's the main physician we work with in the reproductive endocrinology and infertility clinic, for data on patients who had gone through fertility preservation. So included in the chart review were all patients who signed the I-SPY 2 screening consent since the beginning of the study in April 2010 through April of this year, 2015. For those of you not familiar with I-SPY 2, the main pre-eligibility criteria to make you eligible to sign this consent form are that you have a confirmed diagnosis of invasive breast cancer and that the tumor be at least 2.5 centimeters on clinical exam or imaging. We then added the additional criteria for this study that the patients be 42 years of age or younger, since that was sort of the age range where they would still potentially be interested in childbearing. So a total of 79 patients were reviewed and analyzed for this study. So here's a lot of background information about the whole cohort of these 79 patients. I'll point out a few kind of key things to look at here. The mean age in the group was 36.5 years old. About half of the patients in this group already had at least one child, biological child, and about half did not, a little less than half, 46%. The patients at the bottom, we looked at their receptor statuses, and this kind of reiterates the point that I made at the beginning about women with young breast cancer tending to have, on average, more aggressive breast cancers than their older counterparts. Almost 50% of the group had triple negative or HER2 positive breast cancers, which we know are more aggressive. Of the patients who screened at I-SPY in this period of time, who were under this age, 66% of them came back neonatal high risk and were eligible to continue on to the study if they wanted to. All right, so of these 79 patients, 35 were seen by the REI clinic, the Reproductive Endocrinology and Infertility Clinic, 44.3%. And 30.4% of them actually did harvest eggs or embryos before beginning their treatment. So the first question we wanted to ask was, does for this process of preserving fertility, or at least kind of having a consultation to think about preserving fertility, does it cause a delay in treatment? So we looked at 54 patients within the 79. These were the group who had neoadjuvant chemotherapy at UCSF, and counted the number of days between the first visit with a surgeon or oncologist at which they had a discussion about neoadjuvant chemotherapy in the I-SPY2 trial, up until the day that they actually started chemo. So the average for the entire group was 27.3 days. Again, this is not the time in screening, it includes the time up until screening. And we looked and found, luckily, that there was no significant treatment delay between patients who had a consultation with the REI clinic and those who didn't, nor was there a significant treatment delay between the patients who harvested eggs or embryos and those who didn't. It is notable that the range of days of this time period was incredibly large. There were some patients who delayed for a number of months even for a variety of reasons, largely sort of social reasons or pursuing alternative therapies. But even when we did this analysis, taking out these two outliers, the ones in the 70-day range, there still was not a statistically significant difference in the amount of days. All right, so next we wanted to look and see whether we could find any differences in patient or tumor characteristics between first the patients who consulted REI and those who didn't, and also between the patients who harvested eggs or embryos and those who did not. So the first variable that we looked at was age. And we found that actually there was a statistically significant difference in the age of those who had a consultation and those who didn't. Younger women were significantly more likely to go to make a consultation with the fertility specialist. And between those who harvested and those who didn't, it wasn't quite statistically significant, but trending towards the same type of trend of younger women being more likely. Next, we looked at their gynecologic history, so the number of prior pregnancies and the number of prior births, the number of biological children that they already had. And in this category, as you might expect, and it kind of confirmed our prediction that women who came in having no children or fewer children were much more likely to have a consultation with a fertility specialist and ultimately to go ahead and harvest eggs or embryos before starting. And lastly, we looked at some of the characteristics of their tumor and of their cancer. So we looked at clinical stage, comparing the percentage of patients at stage 2 and the percentage of patients at stage 3. And we found that patients who presented with stage 2 cancer were more likely, statistically significantly more likely, to visit the oncofertility specialist before starting. We didn't find the same significance value for those who harvested eggs versus those who did not. And then we looked at tumor grade and found a trend without a significant p-value that the higher grade tumors, patients with higher grade tumors were less likely to visit the oncofertility clinic. All right, so lastly we wanted to know, okay, for those patients who do go ahead and harvest eggs or embryos before they start their treatment, what are the outcomes? So there were 24 total patients who harvested. 23 of those were at UCSF, so we were able to get more information on them. 10 patients harvested eggs. They ranged from 8 to 32 eggs per patient with a mean of 19.2. And then 13 patients harvested embryos and froze embryos with a mean number of embryos frozen at 8.3. Then we wanted to look at who has actually attempted to use these eggs or embryos for pregnancy after they've completed their treatment. And the numbers right now are pretty low. 0 out of 10 women who froze eggs have started or have attempted to use them, but 3 of the women who froze embryos have attempted or soon planning to use their embryos. One of them started IVF, the process of going ahead and using the embryo, less than 18 months after the data for surgery, after finishing neoadjuvant chemotherapy. She unfortunately, the effort was unsuccessful, but they're now pursuing the use of a donor egg. Another is planning on using her frozen embryo with a gestational carrier, a surrogate. And the third is planning IVF this summer with her frozen embryos. She's approximately 3 years out from surgery and has had 3 years of chemotherapy following her, of hormone therapy. We also found in this group 2 metastatic recurrences, at least 2, because we also have 2 who are no longer being seen in UCSF, so we don't know for sure, and 1 death from metastatic disease. So that kind of brings the N potentially down to a lower number than this, since they may be less likely to go ahead and use their eggs and embryos. So in conclusion, this kind of summarizes everything we've already talked about. 43% of patients who met our criteria for this chart review did have a consultation with the REI clinic. 30% actually harvested eggs or embryos. There was no statistically significant treatment delay from either of these processes of having a consultation or going ahead and harvesting. Younger patients were more likely to seek the consultation. Patients with fewer kids were more likely to seek to have this consultation and to harvest eggs. Higher stage cancers had less patients with higher stage cancers were taking the time to do the consult. And then the results of the harvesting, 10%, while the numbers seem pretty small, it's 10% of patients who actually have already used or attempted to use their eggs, and this is within a 5-year period of time, and for many of them less than that if they weren't screened, if they were screened later than the beginning of 2010. And approximately 10% of the patients who harvested eggs and embryos within the past, whatever number of years, at most 5 years, have had a metastatic recurrence or died. So future directions, which, I would hope that maybe someone in the new intern class would be interested in working on with Dr. Chen and others. Of course, there were limitations to the study because it was just a chart review, it was retrospective. But there's a really important need to better understand the current practices surrounding this issue of fertility preservation in these young women with aggressive, late-stage, or locally advanced breast cancers. And so the ideal study would be a prospective analysis of fertility preservation patterns, starting as soon as it can, in all I-SPY 2 clinical sites. We have such a large patient population if we include all of the sites. So a huge thank you to Dr. Chen, Dr. Rosen, and Eve Harris who work in the fertility clinic, Mamta, Dominic, and ET who helped me in my scramble to put these statistics and slides together, Laura and Meredith and Jeff and Shelley for being an incredible part of putting this program together and allowing me to be part of it for 2 years. All of the BCC faculty, physicians, staff, nurses, etc. I work really closely with all of them on a day-to-day basis and have learned so much. Patients on I-SPY 2, like Rebecca said, we can learn so much from the patients we work with, and a special thank you to my interns this year and last year who have made this a really awesome 2 years. Thank you.
Cost analysis? I mean, I imagine this is a pretty costly procedure, and that's why it's a lot to do with people. Is that in any plans?
We didn't look at this now, but it's certainly been looked at and needs to be looked at.
Because insurance doesn't cover, like, typically, right?
No, that's the biggest problem. It's about 7,000 to 8,000, I think, per cycle to harvest, and that's with the cancer discount.
As opposed to a woman who's infertile and doing IVF without cancer.
I mean, I don't think they call it that.
Impacting obliteration of your ovaries with medical treatment. So
there have been no live births?
None in this group.
But this is only
But this
5
is
years.
too
But
early.
I think this is really
And-
interesting, right? That actually 10% is huge that actually go back.
I agree.
to use.
it's a lot. So we normally say especially, and then
Right,
probably
but-
high-risk
but I still-
population. High-risk population, we often recommend that people wait 2 years before they start, and about half the women are hormone positive, so they're on
More than
hormone
half are
therapy.
hormone receptor positive.
That's
Our
so
young
good.
patients at UCSF, for whatever reason, we have more that are ER positive.
No, in
probably.
this setting, they're in 50%.
55%.
But overall, we have a lot of ER positive patients, and they wait a long time. I mean, sometimes more than 5 years.
But I think this is speaking to not everybody waits a long time. And actually, the one of the 3 that have gone back to use her embryos, has a metastatic recurrence, and she is going back to use a
Yeah.
surrogate in the setting of metastatic disease. So I think, you know, it's a reminder not to sort of pass judgment on if and when they're going to use, because one of these three are doing it in the setting of metastatic disease.
I totally, I mean, I agree. I don't think that we should. I think there's a lot of issues with the metastatic disease, particularly in
Right.
triple
I
negative
mean,
population.
I agree, but
This is so important.
if they
We had a
want to-
patient who came to us who got really, really anxious about starting because of inappropriate information given by our colleagues. But, you know, you have to start in 10 week, you know, so, you know, HER2 positive disease, young woman in her 30s, mid-30s, said she had to start chemotherapy, and the choice of chemotherapy was TCHP, which is not the one that we use as part of I-SPY, and has more permanent ovarian suppression than the regimen we use. So she started, and then she transferred to us because she liked us better anyway. And you know, I tried to then harvest eggs after that first cycle because they had told her she couldn't do it, right? And they don't, and they have support down there in the South. Okay. And but you know, I mean, people have support. It's hard. You know, if you live in the middle of the country, you could have no fertility person to go to, so they have support. And anyway, she didn't go. We couldn't harvest eggs, and she hasn't recovered her ovarian function. So this kind of stuff, just allowing people the option is so important.
So Tess, if we were, so going forward, you know, this is a perfect little grant for someone to write up to be able to incorporate a survey into the trial. Not only do you want to get this data, what other data do you want? What data in particular would you be looking for, like from patients?
Well, that we could ask and sort. I mean, I'm interested in knowing perhaps descriptively what each patient's kind of thought process was when they were determining whether or not to have a consultation, whether or not to harvest eggs. And that's kind of what got me interested in the project, because a couple of the patients on I-SPY 2 who I worked with as the coordinator, you know, talked about this with me a lot, and I thought it would be interesting to look into more.
So it's that quality of life, right? Getting a sense for what, I mean, for some people, just having some control of not having the door shut.
Right.
There are a lot of people who do it, not because they're sure they want to have more kids, but because they don't want that door.
Yeah, and there have also been women who, you know, in reading through the notes, who have changed their minds about it, who were very, you know, focused on preserving their fertility before treatment, and now that they're a couple years out, I was reading a couple who decided they're probably not going to go ahead with it now. You know, like life circumstances change, but the availability of having that option in advance is important.
But I think for the context of I-SPY, I don't think there's any or very little data about doing this in neoadjuvant setting.
I agree.
For us to describe it in I-SPY is huge.
Yeah.
So
I
this
agree.
is
We have such big numbers.
The point of my study
is
was,
the manuscript ready? Are you meeting with Joe this week?
We can do some West Coast, East Coast.
but the point of the story is that people
look
don't
at that
know.
once you
And that's the issue, is that other academic centers will say it's not safe to wait 2 weeks. And that's
Well,
what's
what's the
really
most
good about
important-
this,
okay,
is
so
you're
what is
really
that
doing
data?
something important.
The most important data that I thought about here,
Is
so
the
what?
no delay.
Not only is it
Yeah, I mean,
but
it's actually 4 weeks.
About 27 days.
Well, and I will say that the reason it's, I mean, that's under a month, right? It's because Mitch does the random start.
Yeah.
So I don't know if they do that across the country,
Right.
but he believes.
Random start, meaning not related to the cycle of their period.
It really, I think that's really interesting. So I just also want to remind people, for those of you who are leaving and have manuscripts that you could write up. It's already in there, it's like, well, the meeting we look at. I know you think you'll get it done later, but not so likely. I would encourage you in these waning few months before you start medical school, to write it up this week.
Few months.
I would say, deadline, like is this week. Write it up. This weekend, meeting to work on papers. I'm available. All right, so you're available. I'm available. So really, I do want to encourage that, because you know nothing like a deadline. And it's easier. You'd be surprised. You've got these presentations, right? I mean, Hope has made these. Triple A has helped you put these great presentations together. Turn it into a manuscript. It's really very formulaic. It's a good thing to learn. I encourage it. Okay, Tess.
So I'm Tess. I'm another one of the outgoing interns this year in the Breast Care Center. And what I learned this year, I learned a lot, but the major thing I learned this year was how many factors there are to consider when looking at an individual patient. In lab, I work in a Campbell lab. We look at the biology of cancers and how there are biological risk factors for cancer, but also through decision services, I've picked up on how important it is that the doctors pay attention to the social and emotional and psychological individualistic qualities of the patient as well. So one of my projects was looking at biological risk factors for breast cancer, and in this light we are exploring the microbiomes of breast cancer patients. It's a new project this year. So I'll start with a little bit of background about the project and why we're studying this, and then I'll talk about the progress and give a sneak peek into the very preliminary data that we've collected, and then I'll talk a little bit about future directions. So the human microbiome is defined as the aggregate of microorganisms that coat the insides and outsides of our body. And things like bacteria, fungi are associated with illness commonly, but the sheer number of microbes that we carry implicates an important dynamic between our bodies and the bacteria that we host. There are 10 times as many microbial cells in our bodies as human cells, and they encode 1,000 additional genes, and they make up 3 to 5% of our human body mass. And research has shown that the microbes that exist in distinct sites in our body are different because they utilize carbohydrates, sugars that exist at those sites. So these sites include the oral mucosa, the skin, the gastrointestinal tract, and others. So immunity is essential. Bacteria are essential for normal immunity and normal digestion. But when the balance of bacteria in the body is off kilter, it can lead to pathogenic effects. Microbial dysbiosis has been implicated in diseases such as diabetes and obesity and inflammatory disorders. And interestingly, there's been a proven association between periodontal disease, which is chronic inflammation of the mouth, and breast cancer risk. And the gut microbiome has been most closely studied in the context of inflammatory bowel disease, and this is a known risk factor for colitis-associated colorectal cancer. And I think it's interesting also to note that chronic antibiotic use, which causes microbial dysbiosis by depleting some of the bacteria in our body, has also been associated with an elevated risk for breast cancer. And inflammation is known to play an important risk in breast cancer, but it kind of takes on a double-edged sword role. Immune responses are known to prevent the development and growth and spread of tumor cells. However, host inflammatory responses can also contribute to the growth of cancer by producing cytokines and growth factors that directly or indirectly enhance tumor development. So in the wake of this new appreciation for the bacteria in our body, there has been a huge push to understand the role of the microbiome in health and in disease. And we've made a lot of progress over the past 20 years in understanding breast cancer biology and developing new treatments, but it's estimated that 70% of sporadic breast cancers, the etiology of these cancers is still unknown. So it's essential to answer this question of whether microbial dysbiosis could be contributing to the etiology of these sporadic breast cancers in order to develop new preventative treatment strategies and risk-reducing strategies that could be based around probiotics. So in this light, my PI, Dr. Michael Campbell, conducted a pilot study in 2012 in which he collected oral rinse samples from 12 patients with invasive ductal carcinoma and 10 age-matched healthy controls. And the goal of this study was to see if there was any significant difference in the types of bacteria in the mouths of breast cancer patients and healthy women. And he wanted to study both the diversity of bacteria in the mouths of these women, as well as the most abundant bacterial populations. And although there was no statistically significant difference in the diversity of the bacteria in the mouths of these women, he found that in healthy women, Streptococcus was the most prevalent bacteria in the mouth. But in patients with invasive ductal carcinoma, Prevotella was more prevalent. So this pointed to an interesting pattern that in breast cancer patients, there may be different levels of bacteria at distinct sites in the body. So now we're making a push to conduct a much larger study to both validate and extend the results of the pilot conducted in 2012. And the first question we're asking with this larger study is there a link between the oral, gut, and or breast tissue microbiota and the incidence of breast cancer? A study published in 2014 showed that there is, in fact, bacterial DNA in the breast tissue, and that breast cancer patients showed elevated levels of a bacteria called methylbacterium. So we're interested to see at which site these changes are most prevalent. We're also interested to see whether patients with DCIS have more similar microbiomes to healthy women or to patients with more invasive disease. And lastly, we're interested in knowing how known breast cancer risk factors such as genetics and lifestyle may or may not be related to the microbiome. So very briefly, we're conducting this study by enrolling patients out of the Athena Screening Clinic and out of the Surgery Breast Clinic. We give patients their own bacterial DNA collection kits, which they take home and send their samples into a company we're partnering with called Ubiome. Ubiome sends the data back to us, and we run clinical correlations. We're also collecting tissue from a select cohort of these patients at surgery, which we will eventually, hopefully, digest and find the bacteria in those samples. So we've enrolled over 30 patients out of the Breast Cancer Center for this trial, and Ubiome has returned data on 12 of these patients. So 10 of these patients that I analyzed for this project were diagnosed with invasive ductal carcinoma. One had a BRCA2 mutation, one had a diagnosis of ductal carcinoma in situ, and one was a woman who came into the Breast Cancer Center with a BRCA2 mutation in order to receive a prophylactic mastectomy. And there was a range of grade and race profiles in these patients as well. So the statistical power here is low, but it was my goal to just start looking into patterns of the microbial profiles in these women. And so the first thing we looked at was at the genus level, the oral microbiomes in healthy women in the DCIS and invasive ductal carcinoma cohorts. And we found that Streptococcus was the most prevalent bacteria in all 3 of these cohorts in this study. And this is different from the results that we found in the 2012 pilot study, in which Prevotella was more prevalent in the patients with invasive ductal carcinoma. And reasons for this difference could be sampling procedure. So in 2012, we collected oral rinse samples. In this study, we're collecting a swab from the inside of the patient's cheek. But also, these data could be subject to random forces as well. Similarly, when we separated the patients out by grade, we didn't see any significant changes in the most prevalent bacterial type between the patients with grade 1 cancer, grade 2, and grade 3 cancer. Interestingly, though, when we looked at the gut microbiomes of these patients, which we studied through a stool sample, there were some interesting differences. So the bacterioids are commonly accepted as the most prevalent bacteria in the human stool. But when we looked at the DCIS and invasive ductal carcinoma cohorts, they had a much more elevated level of Faecobacterium. And what we know about these bacteria is that the bacterioids belong to a phylum called Bacteroidetes, and Faecobacterium belongs to a phylum called Firmicutes. Apologies if I'm pronouncing this wrong to the infectious disease doctors. But what we know about these phyla is that in obese individuals, there is a much more elevated level of Firmicutes phylum, which the Faecobacterium belongs to. And Blautia, which also is found to be elevated in the DCIS and invasive cohorts, also belongs to the Firmicutes phylum, which is elevated in obese individuals relative to lean individuals. And it's also known that the bacterioids exert a protective force against colitis in the gut by modulating immune responses there. So it's interesting that patients with a breast cancer diagnosis showed different patterns of the Firmicutes and the Bacteroidetes phyla. We saw a comparable elevation of the Faecobacterium in patients with higher grade diagnoses, with the Faecobacterium being the most prevalent genus in the grade 2 and grade 3 patients, while the bacterioids were still the most prevalent in the grade 1 patients. Next, I thought it would be interesting to look at the microbiomes of the 2 BRCA2 carriers that we studied in this study, to see if the healthy BRCA2 carrier had a more similar microbiome to someone without a BRCA2 mutation versus the cancer diagnosis. And in this case, the woman who had a BRCA2 mutation but did not have a diagnosis had a more similar profile. Oh, sorry, this is the oral. So there was no significant difference in the oral microbiomes of any of these patients. But when we looked at the gut profile of the woman with a BRCA2 mutation who did not have a diagnosis was more similar to the healthy patient without a BRCA2 mutation as opposed to the patient with a breast cancer diagnosis. So the next steps is to continue enrolling patients on the study so we can get more statistical power for these patterns. And Brianna and Etienne and Sarah will be working to enroll patients over the next year. And then we would like to investigate lifestyle factors to see how things like diet and exercise regimen may play in. And we have those data through the Athena intake form as well as the Ubiome lifestyle survey. We also would like to study the breast tissue microbiota, which we're collecting currently. And then the idea is that if there is an indeed association between breast cancer and an altered microbiome, we hope that this work may contribute to the development of preventative treatment strategies as well as reformed prolonged antibiotic practices. And a huge thank you to Mike Campbell and Laura for conceiving of this project and allowing me to play a role in it, as well as the surgeons and nurses who have helped me so much to enroll patients, everybody who is on the internship program team and the decision services, Shelley and Jeff, who gave me enough experience in the clinic to be able to consent. And the microbiome patients have been wonderful to work with, and also these guys.
Great job. So, Tess, why don't you maybe make one more speculation? So why don't you link this work that you just presented to the other work that you're doing in the lab on looking at immune response? What do you think the possible relationship might be?
Yeah, that was what was originally so exciting about this project was that we know that bacteria play a role in activating the immune system and changing the immune system because they are foreign bodies. And so I think that one connection could be that an altered microbiome, either in the breast or in sites that, that communicate with the breast tissue, may be promoting different kinds of immune responses that either could be more activated or less activated than healthy women. So I think that there's this interesting connection between the microbiome and the inflammation that we know to play a role in breast cancer.
And maybe one last question is if we wanted to think about whether there's an opportunity for prevention by better understanding the microbiome. If you were thinking about trying to insert these kinds of tests, pretty simple to do, patients have been happy to do it, not a problem, right?
Yeah, absolutely.
So where might you think about integrating this?
Well, I've talked to Sarah, who works in the Athena mammography clinic, about this before, and they are already collecting some biospecimen samples from women who are coming in for regular screening. So we have thought about how it would be great to get either a saliva, cheek swab, stool swab sample from these women who we could follow up with over time. And then if they do develop breast cancer in the future, we can look back to see how their microbiomes may have been changing or how they may have been different from women who did not get diagnosed later in life.
So pursuant to that, since you'll still be here next week at 5 o'clock, I think I'm meeting with Bob Hyatt, and we're going to talk about trying to put in an infrastructure grant to maybe add additional markers as we go through the wisdom trial. So why don't you and Mike show up?
Sounds good. Be there.
and Brianna, right? Right?
Yeah.
All right.
That might make more sense.
Hi everyone, I'm Brooke Rice, and I will also be leaving this year. I was here for 1 year. And I think a really important lesson that I learned this year as a clinical research coordinator was how to stay calm when multiple things are happening at once that all seem like really urgent places that I need to be, how to not panic and stay calm when that's happening. And I think that that will be a really important skill as I go forward into my career as a future doctor. Today I'll be talking to you about the results from our Hair to Stay program here at UCSF in preventing hair loss during chemotherapy. So for many women, hair loss from chemotherapy or chemotherapy-induced alopecia is one of the most common and distressing side effects of cancer treatment. Losing your hair means that you can't choose who knows that you have cancer, whether that be your employees and your coworkers, or your children, or the general public. So this is a really important area of research. Cold caps are one method to prevent or reduce this hair loss by cooling the scalp before, during, and after chemotherapy. So the way that cold caps work are that the cold temperature of the scalp reduces the amount of chemotherapy that can reach the hair follicles by constricting the blood vessels that carry the chemotherapy to the scalp, as well as decreasing the cellular uptake of chemotherapy. And although scalp cooling is widely used throughout Europe, until this year there were no studies published on scalp cooling in the United States. So this lack of data, along with a theoretical concern that preventing chemotherapy from getting to the scalp could cause cancer to metastasize to the scalp, have prevented scalp cooling from becoming popular in the United States. However, in breast cancer, it's very, very rare that the scalp is the first site that cancer would metastasize to, and a number of small studies have not shown a correlation between scalp cooling and scalp metastases. So in our Hair to Stay program at UCSF, this year I coordinated clinical trials involving two different types of cold caps. The first was the Dignitana machine, and this is a plastic cap connected to a machine that runs a coolant through it, and the patient puts this cap on about an hour before chemotherapy and wears the same cap until 2 hours after chemotherapy. This was a phase 2 clinical trial, and we enrolled 122 patients at 6 sites across the US. The study is now completed. It's just in the annual follow-up safety checkup stage and is pending FDA approval for the DigniCap. The second type of cold cap that we worked with is the Penguin cap. And this is a set of 14 frozen caps that are like large ice packs that patients strap to their head, and they need to be changed every 20 to 30 minutes. So every 20 to 30 minutes from an hour before chemotherapy to 2 to 4 hours afterwards, a patient has to take a new cap out of the freezer and have someone fit that cap onto their head. This is a registry study, which means that patients independently can rent the caps from the company, and we ask patients who have chosen to rent the caps if we can study their experience with the Penguin cold cap system. We have enrolled 103 patients to date at UCSF, and this is an ongoing study. So I'm going to briefly summarize some of the results that Dr. Rugo presented at the ASCO conference in the beginning of June. In this trial, when patients came in at the beginning, every 3 to 4 weeks during chemotherapy, and at their 1-month follow-up visit, study coordinators took pictures of the patient's hair, and the patients used these pictures to compare them to their original baseline pictures and to assess their own hair loss. And they assessed it using this 5-point Dean scale, where grade 0 is no hair loss, and grade 4 is greater than 75% hair loss. In this trial, we considered success to be up to or including 50% hair loss, because that's generally considered the point at which other people can tell that a patient has experienced hair loss. So this table shows that the overall success rate for the 101 patients who used the DigniCap was 70.3%. So that means that 70.3% of the patients who wore the DigniCap during chemotherapy were able to keep at least 50% of their hair. 29.7% of patients lost more hair than that and were considered treatment failures. And as expected, the 16 control patients who did not use any type of cold caps were also treatment failures and lost more than 50% of their hair. Table 4 shows the success broken down by chemotherapy regimen. And I want to point out the biggest regimen included in this trial, 75% of the patients, 76 patients, received Taxotere Cytoxan, and they had a success rate of 63.2%. So now I'll tell you about the Penguin trial here at UCSF. So we enrolled 103 patients. 3 patients dropped out of the trial due to discontinuing chemotherapy. 2 patients were lost to follow-up. 1 asked not to be contacted further, and 1 patient unfortunately passed away before her follow-up appointment. And 8 patients are currently receiving treatment, which leaves us with 90 evaluable patients. Of these, our biggest group, we have 34 patients who received 4 cycles of TC, Taxotere Cytoxan. 10 patients received 5 or 6 cycles of TC. 22 received our I-SPY regimen, 12 weeks of Taxol followed by AC. 10 patients the reverse, AC first and then Taxol, and 14 patients received a variety of other chemotherapy regimens. Many of these were being treated for metastatic breast cancer. So at the beginning, every 3 to 4 weeks during chemotherapy and at follow-up, we asked patients to assess their own hair loss using this 100-point VAS scale, where 0 is no hair loss and 100 would be total hair loss. And we had the same standard of success as the Dignitana trial, where we considered the treatment to be a success if a patient lost less than or up to 50% of their hair. And we looked at the maximum amount of hair loss that a patient ever reported. So if a patient ever reported more than a 50 on the scale, then we consider them to be a treatment failure. Additionally, if any patients dropped out of the trial because they felt that they lost too much hair to continue, then we consider them to have 100% total hair loss. At follow-up, we also asked patients about how satisfied they were with the Penguin Cold Cap system in terms of how well it worked to prevent hair loss from chemotherapy. So if a patient circled a 4 or a 5 on this, we considered that they were satisfied. And we asked patients if they would recommend the Penguin Cold Caps to another patient receiving the same chemotherapy regimen as them. And patients could choose to highly recommend, recommend to some degree, or not recommend at all. In our biggest group, those who received 4 cycles of Taxotere Cytoxan, our success rate was 85%. So 29 out of the 34 patients who got 4 cycles of Taxotere Cytoxan were able to keep at least 50% of their hair during chemotherapy. The average hair loss reported was 37%, and 1 patient did drop out due to losing too much hair. Of the patients who finished the 33, 97% were satisfied, and all of the patients said that they would recommend this to another patient receiving 4 cycles of Taxotere Cytoxan, 80% highly. In our group who received 5 or 6 cycles, we had a 50% success rate, so 5 out of 10. The average hair loss reported was 44% here. No one dropped out due to hair loss, but 1 patient did drop out due to side effects. And again, the majority of patients who completed the trial were satisfied, and everyone said that they would recommend the Penguin Cold Caps. In our group, our I-SPY group, who received Taxol followed by AC, our success rate was 45%. And I want to note here that regimens containing adriamycin are the most aggressive towards hair, and so while this and are often not included in scalp cooling trials, and often just considered that scalp cooling wouldn't work if patients are going to be receiving adriamycin. So although 45% is less than half, this result is actually pretty impressive because it shows that 10 out of these 22 patients were able to keep their hair even on this most aggressive type of chemotherapy. So the mean hair loss reported here was 57 out of 100, 57%. 2 did drop out due to hair loss and 1 due to side effects. Of the 19 patients who finished, 18 answered whether or not they were satisfied, 77% were, and again, all 19 who finished would recommend the cap to another person receiving TAC. In our opposite group, we had a lower success rate of 20%. Only 2 out of 10 patients in this group were considered a success. 2 patients dropped out due to hair loss and 1 due to side effects. But again, I want to note that of the 6 patients who completed the trial, all of them were satisfied and all of them said that they would recommend the caps. And one thing I want to particularly point out here is that these 2 patients who we considered a success both reported less than 10% hair loss overall. So there's a really wide range of results between from treatment failure to less than 10% of patients who are receiving the same chemotherapy regimen.
But can you just go back one slide? What was the success on the AC? I mean the TC? Just go back one.
85%.
85%.
On 4 cycles.
On 4 cycles. And it decreases.
Yeah. And when was your last time point? Like
how
far out from your last dose of chemo?
The median follow-up is 17 weeks.
After your last dose?
After their last dose. So patients were, it was whenever patients came in for their follow-up appointment.
But it is true that if you get used to it with the weekly Taxol, you do much better with the AC than if you start with AC.
Yeah, I mean,
it's so funny that it's all training.
Yeah.
Well, we have different group
Different
sizes here,
patients,
but
it's also, yeah, absolutely.
But yeah, I really want to note that these 4 patients here who finished, but we considered treatment failures, were very satisfied with their experience with the caps. So in our a group of other regimens, and the reason this adds up to more than 14 is because some patients received more than 1 regimen. Many of these were metastatic patients, so they might be going onto these drugs not knowing how long that they'll be on this drug for. We had a 64% success rate. More patients dropped out due to hair loss and side effects. But again, I really want to highlight that all of the patients who finished and didn't drop out said that they would recommend the CAP to someone receiving a similar regimen. I'm going to skip ahead here just for a second. I want to talk about the tolerability of these. So overall, we had 6.7% of our patients discontinue scalp cooling due to device-related side effects. And the main side effects are headache, which 78% of patients experienced at least once, cold, which is almost 50 out of 100, so that's a pretty high level of cold, and scalp pain, average of 33 out of 100. So excuse me while I go back here. Okay, so overall, 55 out of our 90 patients, or 61%, were able to successfully prevent hair loss during chemotherapy. And I really want to emphasize that 32 of these were receiving that most aggressive chemotherapy drug, 32 of the overall, not the success. 15% of our patients dropped out, 8 due to hair loss and 6 due to side effects. But of the 76 patients who completed scalp cooling, all of them said that they would recommend the Penguin Cold Cap to someone receiving the same regimen as them. So some future directions, we would like to know what is the optimal post-cooling time. Patients use a wide range of amounts of hours of cooling afterwards, and this could account for some of the variability in our results. Do patients take extra medications because they're doing scalp cooling? Why do some patients choose not to use the caps? And how do patients modify their normal hair care regimens? Could this account for some of the variability as well? So some preliminary results. I was able to contact 50 of the 90 evaluable patients, and 44 of them remembered how many hours of scalp cooling that they had done after chemotherapy. The mean time was 2.85 hours with a standard deviation of 1 hour, but there was a really wide range of 1 to 6 hours. So this really merits further investigation. Is it necessary for that patient to wear that cap for 6 hours afterwards, or could they be okay with 2 hours possibly? And do patients take extra medications for scalp cooling? The 48 who remembered, 67% of them did take extra medications, mainly anti-anxiety or painkillers ranging from over-the-counter to stronger prescription from their doctor. And we've now added new survey questions about how many hours patients did after chemotherapy and whether they took extra medications. Some future directions for Leonie to take over. We submitted a new study to CHR to call 300 past patients who've agreed through Athena to participate in future research, who received chemotherapy but did not use the cold cap. So we'd like to assess the barriers to cold cap usage. Did these patients even know about scalp cooling as a possibility? And if so, did they consider it? And what were their reasons for choosing not to do it? And then to our survey, we've added questions about changes to patients' hair care regimens, such as how many times a patient washes their hair per week, because this could be something really important in accounting for some of that extreme variability in patients who receive the same chemotherapy regimen. So I want to say thank you to everyone who has really supported me throughout this year, and good luck. I'm excited to see what Leonie, where she takes this project in the future.
Why do you think people were, what do you think accounted for the disparity in what you label as success and what patients found successful?
So I think what we labeled as success was, can other people tell that a patient has lost hair? And that point we generally said is 50%. But for many patients who lost more than 50% of their hair, I think that some reasons why they were still satisfied is that if you lose all of your hair, it can take years for it to grow back to its original length. However, if you just lose some of your hair, as soon as you start having some hair regrow, your hair can look much fuller and more normal much more quickly. So I think that even for patients who were considered a failure by the 50% success rate, they were still satisfied with the amount of hair that they were able to keep. And many patients said that they could wear a hat and not have people know that they had lost hair, or that in general their hair recovered much more quickly after chemotherapy.
So they say that at 3 months, you know, your chance that you look, even if you've lost 50% of your hair, you look pretty normal at 3 months. When your hair comes back in, do you have a measurement point at 3 months?
Of
3 months post chemo.
No, so what we used is the whatever follow-up point that the patients came in to follow up with their oncologist, and the mean time was 17 weeks.
Yeah, so going forward, your advice to Leonie in inserting a new data point would be?
3 months.
Something like that. Because I think that's actually really important. Again, it's beauty's in the eye of the beholder, right? So it's, you know, the actually treatments are not for us. So we want to make sure that we're measuring something that's of material importance to our patients. And, you know, all the things you said are important. You know, what do you mean I can't color my hair? What do you mean I can't wash my hair? Or what, you know, so it. But in a lot of the advice isn't one of the hard parts of your job, is trying to filtering out the advice that comes down from the owner of the Penguin Cold Cat site.
Definitely.
Yeah. So trying to demystify it.
Don't wear deodorant. Is their advice.
Stay for 4 hours. No data for that. Yeah.
So I'm just curious if there's any kind of differential in like texture of hair, like is there lots of studies on different races, different types of hair, different textures, et cetera? I was just thinking in terms of bodies with different skin pigmentations.
Yeah, so that's not something that we looked at in our study. There was a scalp cooling registry, a Dutch scalp cooling registry that looked at 1,411 patients, and they found a significant result that patients who had Asian hair did less well. But that's been the only result that I've seen that differed by ethnicity.
I think people who have really thicker hair, you do probably a little better because you can't see. If you have really, my experience is when people's like really, really thick hair, you can't get the cold in. It actually is a really, hair is a good insulator.
Yeah.
And when you have really, I had someone incredibly thick hair and a complete failure with the caps that, I think she was in the Digna study.
Well, one comment I'd like to make is that when you do lose your hair, that up to 50%, it's a general thinning of your hair and not like a big bald spot somewhere. So you actually can lose a good amount of your hair without having it obvious that you've lost hair. Tessa?
So you did not survey the patients who stopped using the caps about whether they would still recommend the treatment? Or
No, we assumed that they would not, but we didn't actually. But that wasn't included in the satisfaction measure.
Okay. That might be worth including because people who failed were still recommending it. I wonder if they would still say it was worth a shot or something.
Yeah, I don't know. I do think that for patients for whom this didn't work, who did drop out, that it was a very distressing experience for them because I think at the beginning of chemotherapy, if you know you're going to lose your hair, that's one thing. But if you are spending thousands of dollars and trying really hard and freezing your head to try to keep your hair and then you still lose it day by day, every day you're wondering how much more is going to fall out, I think that can actually be a negative effect on patients' quality of life.
Okay, thank you.
It's Ed, or ET as pretty much everyone knows me. And mostly what I've worked on this year is a lot of data entry. So path reports, entering CRFs into the CLGB website, iMedidata, RedCap, Encore, you name it, I've done it. So what I've learned most this year is that, excuse my language, but most data is shit, and it's hard to keep track of, and it was sold on the idea of the eSource checklist at the beginning of the year, so I think it's going to be
a perfect person to write that paper. To give you all over that paper. Yeah. Love that passion.
Yeah, so I just see it every time I enter data. I'm entering the same data that's already been entered into CoPath, into Apex, then for path reports, then I put it in the same database. It gets repetitive. It's redundant. Doctors are putting the same notes over and over again in Apex, typing them in, typing the same thing over again. It's a lot of loss of efficiency. So.
I saw that. Now I'm going to have to talk to you. Now I think you're going to have to go with medicine now.
Well, that's why we had you enter it in 4 places.
Yeah.
Make the pain stop.
So what I'm going to be talking about is a retrospective review of patients at UCSF that had sentinel lymph node surgery and axillary dissection after neoadjuvant chemotherapy. And it's all these patients were node positive at presentation. So I'm going to look at what happened to them and what the false negative rate was. So just a little bit of background for those that don't know too much about axillary surgery. The axillary nodes are one of the more important prognostic factors right now for invasive breast cancer. As you can see, these are all the nodes level 1, nodes level 2, nodes level 3 nodes, and the presence of cancer within these nodes can influence your local, regional, and systemic treatment following your surgery. And to be able to get the information on that presence of cancer, the standard has been to take out, as in a complete axillary dissection, take out all 3 levels of the nodes, which can be anywhere from around like 5 to up to 30, even more nodes. And that comes with a lot of associated morbidities. That could be lymphedema, you could develop a seroma, hematoma, paresthesia, which is numbing, tingling. You could have a wound infection, and you can reduce the range of motion in the arms that you're taking out a lot in the armpit area. So as a new technique that's been introduced in the 90s and now in the 2000s was the sentinel lymph node biopsy. And this meant that you didn't have to take out those 5, 30 nodes. You could take out 1 or 2. And what you do is you inject either a dye, which would be isosulfan blue or another blue dye, or a radioactive colloid. So what we use is technetium-99, and it's radioactive. You use a probe, and you'll be able to detect where the first few nodes are that drained out the liquid that you injected. And then you take out just those few nodes. And so you'll be able to get pretty good information if there's cancer in those first few nodes. It'd be anywhere from like 0 to 5 nodes that you can get out in this way. So in many cases that for patients you don't have to get an axillary lymph node dissection. You're saving them from all these morbidities. But there's also this problem of node positive patients at presentation. They've had a biopsy or a PET CT that shows that they're most likely have a positive node. And many studies are disagreeing on the role and accuracy of the sentinel lymph node biopsy for these patients, and the standard of care right now is still an axillary dissection. So why is that the problem? Why is the sentinel lymph node not the best option? And the problem is that you could have a false negative. And what happens in the false negative is rather than the sentinel node having cancer, you have one of these past nodes that has the cancer and nothing in the sentinel node. And right now, a lot of retrospective studies have shown that that rate in clinically node negative patients can be anywhere from 0 to 20%, but it's more likely somewhere around 5%. But for the node positive diseases, which you already know there's cancer in the nodes before you have surgery, the false negative rate has ranged from 7 to 25% from smaller studies. It is generally agreed upon that if the false negative rate was less than 10% for these patients, it might be suggested to do just a sentinel lymph node for the node positive patients. So there's been a few prospective trials, large trials. The American College of Surgeons Oncology Group, their Z1071 trial found in about 600 patients that they sampled, there was a false negative rate of 31.5% for women with 1 sentinel lymph node removed. These were all patients that were node positive at presentation. But if they took out 2 or more nodes, that rate dramatically decreased to 12.6%. Recently at San Antonio, the French GANEA 2 trial was presented on a poster, and that showed very similar numbers where 24.5% went down to 12% when 2 or more nodes were removed. But again, that 12% is still higher than 10%. It doesn't make up enough of a difference to be able to accept sentinel lymph node as the standard. So what happens at UCSF? All this data does not have any UCSF in it, so what happened from 1995 to 2003 in an earlier paper, 23 patients that were node positive out of the 53 they evaluated had sentinel lymph node, had an axillary dissection, and only 1 of them had a false negative node, so that makes a false negative rate of 7.7%. The way you calculate it is the false negative node over the total amount of positive nodes, not the total amount of nodes that were taken from everyone. So that, if it's a little confusing, it's 1 divided by 13 here, not the 1 divided by everyone they looked at. So what I did is from 2004 to 2014, I asked the California Cancer Registry for every patient that was clinically node positive at presentation, had neoadjuvant chemotherapy, and had a sentinel lymph node and axillary dissection. What I found, though, after I went through all 379 patients, is that only 80 of them had a sentinel lymph node and axillary dissection. So that data was shit. So just a few characteristics. Patient age, the median was 44, a slightly younger population. And most of them were T2 or T3. You had, most of them were ER positive, HER2 negative. Almost 25 of them were HER2 positive. And one thing is, in this retrospective, I did count the people who were node positive by PET CT. Most the other trials that you saw only did by biopsy or FNA. So the numbers might be a little off because of that. Most patients had some sort of taxane adriamycin-based treatment. A few had carboplatin. The HER2 positive people had Herceptin, and one person actually had neoadjuvant TC. On clinical exam after the chemotherapy, 55 did not have any more palpable nodes, and 25 still had palpable node. It was pretty much split between lumpectomy and mastectomy, and when you look at the number of sentinel lymph nodes that were taken out, 49 of them had one, so that was another part of the trial that was different than prospective. So in those 80 patients, 37 had no disease left. Chemotherapy worked. They had a nodal PCR rate of 42 to 6%. But in 43 of the patients, you had 8 with only a positive sentinel node or sentinel nodes, 21 that had positive nodes in the axilla and in the sentinel node, and 14 with positive axilla and negative sentinel node. These are the false negatives, and that's a rate of 32.6%. It's not good. So in the Z1071 trial, what they were looking at is how many nodes you take out for the sentinel node. Does that affect your false negative rate? And it did. Then when they were comparing from 2 to 3, the false negative rate decreased by 12%. And so for us, there was only a difference between 1 and 2 because there was very few people that had more than 2 lymph nodes taken out. And that rate did decrease by about 6%, but that was not statistically significant. There was not enough patients to look at. Also in the Z1071 trial, they used both the dye and the radioactive colloid, and so they had 2 ways of detecting lymph nodes. They were able to find more usually, and that did reduce the false negative rate by 9.5%. So those were their 2 main statistically significant ways to determine, to reduce the false negative rate. So, can the sentinel lymph node biopsy be used? And answer is no, the false negative rate is too high, or at least not yet. So what can we do to make the sentinel lymph node a little bit better? And that's adding better detection methods. Dual mapping with isosulfan blue and the radioactive color can help. But we're also here at UCSF adding a new device called the Sienna Plus nanoparticles in the CentiMag system. And so this is a iron nanoparticle that is magnetic. And this probe here, rather than looking for radioactive decay, is looking for just magnetic particles. So it doesn't have to cost nuclear medicine. You can actually, the particles are supposed to be just as effective, and we'll be seeing this in the new trial. So if we can use possibly more than one mapping agent, we might be able to find more lymph nodes. And why is it important to find more lymph nodes? Obviously, if you have more things to sample, you're more likely to find cancer while reducing the morbidities. And so when I looked at the old PATH database from 2000 and on, there's been 2,309 sentinel lymph node biopsies at UCSF overall between all patients. And most of them, as you can see, have been only one sentinel lymph node has been taken out. And so if we could just jump this number over to 2 or 3, you might be able to reduce that false negative rate by a significant amount. And then another question that came up when I was talking to Dr. Alvarado is really what the future of nodal staging is. What does it mean for a prognostic indicator in the world of genomic assays, the Oncotype test, the MammaPrint, and how can it really inform medical decision making? And so obviously when you have a certain amount of nodes positive, that's going to change your radiation treatment, your tangents, your angles that you're going to take. But in terms of systemic therapy, for the people that are node negative, there's been a little bit of controversy of what you do with the stage 1B patients that have small tumors but node positive. And so there are a bunch of prospective trials for the node negative, node positive people, especially with Responder with his Oncotype, and then MINDAC, which is with MammaPrint, to look at the role of chemotherapy in node positive patients and see if we can better treat patients without over-treating them. And so this is creating a balance between getting enough information from the nodes while also limiting the amount of lymphedema, the amount of other complications that you can get from the axillary dissection. And so hopefully in the future we'll be able to get a good balance to spare people from losing all those nodes. I just want to say thank you to everyone, Dr. Alvarado, Dr. Esserman, Meredith, Natalie, Janice, everyone at the internship, and if anyone has any questions.
So 2 questions for you. The first is, did you look at whether there's variation amongst the surgeons in the number of nodes?
So only 2 surgeons were since this is not standard of care, only you and Shelley Wang were the ones doing the sentinel lymph node biopsies for clinically node positive patients.
With axillary node.
Yeah, so all those other, out of the 379, the other 299 all had full axillary dissection, no sentinel lymph node biopsy.
One other comment is that if you have, what is the problem with this false negative rate? So if we were to switch and do just sentinel nodes, what's the problem for a trial like I-SPY? What's the endpoint of I-SPY? What's the primary endpoint?
PCR.
Pathologic complete response, right? So what's the problem of doing sentinel node only in that situation?
False PCRs, if there's actually still.
So it's hugely important. This is a drug. These are intended to be drug registration trials, so we're really trying to look at the impact or efficacy of drugs and graduate them if they're really working. So if we are falsely identifying that they've achieved a PCR when in fact they haven't, and especially because disease in the nodes is the most adverse prognostic impact, that's a huge problem. And that actually is going to be a big problem for us in the I-SPY 3 trial, which is the international trial, trying to figure out, we actually, one of the things that we're really going to have to address amongst the surgeons, because a lot of people now just want to do a sentinel node, or they'll want to take out a sentinel node plus, you know, a clip node that was positive. So we have to figure out what the standard's going to be, or it'll screw up the entire ability to shortcut these long adjuvant trials using the neoadjuvant model. So it's really an incredibly important area.
How does the funding, so if a patient is going to have a complete axillary dissection and you add on a sentinel node biopsy for essentially research purposes, is my understanding, who is paying? Is there a grant right now?
I wouldn't say it's research purpose. I would say that, you know, when you take out a sentinel node, that node gets examined more carefully.
There's also the possibility that it's examined frozen section to determine how much of it. So a complete axillary dissection goes up to level 3, but if it looks like there's a good response in patients, I think Laura does this a lot. If there's no cancer in that sentinel node that you send off for frozen section, you'll cut it off at level 1 instead of going even
level 1 and 2.
Yeah.
But not do level 2.
So, but insurance is covering it also.
Yeah. And the other thing too is, you know, you don't want to miss, so you're going to look more carefully at the sentinel nodes. Someone presents with really big, thick axillary nodes. You know, what happens is you get to divert your lymphatic stream, so that's probably why you get that false negative rate. And in that setting, perhaps I'm just adopting my own coverage with evidence development. Right. I'm just helping the insurance companies along with coverage with evidence development because you're anticipating what the future will be. And there's now data on, you know, people are now biopsying and clipping nodes that are positive, and if you take that out and your sentinel node, that has better predictive value and maybe avoiding axillary dissection. Again, we're going to have to really figure out.
In another case for detection, like using more than one dye, is just that chemotherapy will affect your lymphatics, a lot of more fibrosis and stuff, and so you have particles of different size might be able to get to the places where one could not. So it'd be a case for using at least, a lot of places actually do use dual agent here, and we're starting for the Sentimat trial. We have to use all 3, so that'll be a good 40 patient to see what
goes. And you said how many patients do we have sentinel node biopsies on one?
2,309. Not patients, but we've done 2,309 sentinel node biopsies.
That is a place where you can look for a variation in the number of nodes that are taken out.
Yeah.
That's still pretty fun. Okay, thank you. Great.
So yeah, my name is Mamta. I spent the year working in the I-SPY 2 project management office and decided to do my final project and presentation on a cost analysis and operational efficiency analysis looking at how traditional clinical trial models operate and where I-SPY 2 stands in relation to that. So I'm going to start off by talking a little bit about the current challenges in the clinical trial model, not outside of I-SPY 2. So as this graph shows, it takes a long amount of time for drugs to go from preclinical to the market. There are a significant number of volunteers, really high costs, and this poses 2 major problems, one for patients and one for our pharmaceutical partners. for patients, there's a long time lag between when the drug is in preclinical development to when it actually gets to the market, therefore making it challenging for patients to get the drugs at the time when they need them. For our pharmaceutical partners, the long times of development, the high investment of resources and costs makes it really challenging for them to be incentivized to develop drugs in targeted therapies where their revenues may be potentially lower just because of they're looking at a smaller patient population. So iSpy seeks to address some of these problems, first by developing a linked phases of development by allowing drugs to move seamlessly from phase 1 to 2 to 3. There are also a variety of operational and design efficiencies. For instance, the model of adaptive design ensures that patients are able to be randomized to treatment based on their tumor biology. And finally, the ultimate iSpy goal is to really develop a model that can be adopted in other disease areas. So in essence, the premise of the iSpy program is really that we're efficient and more effective than other traditional clinical trial models. But I really wanted to see if the evidence really supports the claims. And so therefore, I wanted to spend this year and next looking at where iSpy stands in relation to traditional clinical trial models and whether or not we are as efficient as we say we are, and if we're not, how we can continue to improve upon our model. I thought that this would provide benefit to our internal team because I thought that understanding where we are in relation to traditional clinical trials would allow us to further understand how we can improve. And to our pharma partners, I think that understanding the benefits of the iSpy model in comparison to traditional clinical trials will incentivize them to invest more in the iSpy program and to really make the iSpy program a need-to-be model rather than a want-to-be model. So I divided this analysis into two parts. The first part is what I'm going to discuss today, where I looked at the cost for traditional clinical trial models and looked at the returns to our pharmaceutical partners based on that. And the second is what I hope to do next year, where I use the data I collected this year to really compare where iSpy stands in relation to traditional clinical trial models, and based on that data, how we can continue to improve our operations and our costs. So I'm going to spend this time now going over the analysis that I did looking at traditional clinical trial models this year. I started off by looking at the cost of clinical trials, looking at revenues in a given indication in a given setting, and then looking at net present value as my proxy for returns. So to spend a moment here talking a little bit more about net present value and kind of grounding our understanding in what that means in terms of returns. So net present value, as you see here, I put up an equation, is your probability weighted revenues minus your probability weighted costs over the course of a given period of time, discounted back to account for the time value of money, because $2 million today is worth more than $2 million 10 years down the line. So let's take a look at an example. For instance, take a look at a company like Apple. Before Apple begins developing products, so what they would do is they would look at, all right, well, what would be the revenues generated from something like the iPhone over the course of X number of years? What are the costs for those development? Looking at things like marketing costs, looking at development costs, looking at software update costs, and then what are the returns today, in the present day, based on what we forecast out to be our costs and our revenues. So I used the same kind of analysis looking at drug companies, and when they would look at what are the revenues that we can get in the future if we invest money today in developing this drug. In my model, I sensitized a variety of factors. I looked at the number of exclusivity years, I looked at the number of years of development, I looked at per patient costs, number of patients, per site costs, number of sites, and overhead costs. The factors that I kept constant were revenue and number of patent years, which is 20 years for any given patent. So this slide shows some of the costs that I found. As you can see, from phase 1 to phase 3, costs significantly rise. And that's not necessarily because the per patient cost or the per site cost from a phase 1 to a phase 3 trial is so much higher, but it's the fact that you're increasing the number of patients almost tenfold and you're increasing the number of sites almost fivefold. So that explains why going from phase 1 to phase 3 really drives up costs. And I think the important thing about the iSpy 2 program is we're looking at these drugs in the phase 2. So if we're able to fail early and fail often, as Laura often says, we're able to save our pharma companies the cost of going into a phase 3 trial and failing there. This gave me approximately $220 million to complete one trial for one indication across all 3 phases. Then I looked at the revenues. What are our potential revenues that we can use? And so what I used for revenues is I looked at neratinib, which, as we know, was shown to be positive in iSpy 2 and is going to be entering the iSpy 3 program, hopefully this fall. And so what I did is I looked into some research and found kind of what neratinib's peak sales are, or what the company expects their peak sales to be in the neoadjuvant setting. And then I looked at what traditionally oncology drug growth rates have been and forecasted out the revenues for, the expected revenues for neratinib. Then I used this data to conduct my NPV analysis, and as you can see here, I looked at my NPV analysis looking at 11 years of market exclusivity, 13 years of market exclusivity, and 15 years of market exclusivity. The 13 years was kind of what I developed as my base case. As I found when I was researching, the approximate timeline for development for an oncology drug is approximately 7.8 years, giving you about 12 years of market exclusivity. I bumped it up to 13, and then I used revenues and costs that I found in research to really identify what this middle baseline situation would be. Anything to the right of that would be worse, anything to the left of that would be better. Then I looked at kind of this worst case scenario where I increased per patient costs, I increased the number of patients, I increased the number of sites to really see what our worst case scenario would be if we had 11 years, 13 years, or 15 years of market of development and of exclusivity in the market. And then I looked at a best case scenario where I decreased the per patient cost, I decreased the number of sites, and I decreased the number of patients, looking at what is our best case scenario, assuming we have 11 years, 13 years, and 15 years of market exclusivity. This gave me a really wide range of NPVs, anywhere between negative $43 million to a positive $148 million, and that's just because there's so many factors influencing what the returns that a pharmaceutical company might get when they decide to develop a drug. Things like increasing number of patients, number of years on the market. And so I wanted to look at what this really means for I-SPY. And for I-SPY, what this really means is increasing the number of years that you have of exclusivity on the market is what's key to improving your NPV. In essence, if we can truly just reduce the time to development and increase the number of years that a company has for a drug on the market, you can really increase the returns that they're getting. And then if you're looking at costs, the per patient costs are more important than the site costs. The patient costs are really what is the driver for costs in these clinical trials, especially as you saw with the phase 3, where increasing the number of patients really boosted up the cost of a phase 3 trial versus a phase 2 trial. And so in essence, if I-SPY can truly reduce the time to market, then we really can increase the value to our pharmaceutical companies and hopefully incentivize them to invest in the I-SPY program. And so this table is essentially a table format of the graphs that I previously showed, and that red box highlights that base case scenario, 13 years using costs and revenues that I found from research. Anything that's shaded is ideally where I-SPY wants to be. And as you see, almost everything in that 15-year market exclusivity period is shaded, therefore re-emphasizing that what's really important for I-SPY is if we can shave 2 years off of the development, time to development, that's how we can increase returns for our pharmaceutical companies and get them to invest financially in the I-SPY model. As with any analysis, my analysis did, of course, have limitations. They did not account for the impact of taxes and how that would impact costs and revenues. A lot of my assumptions were based on literature, which means there was a heavy reliance on averages. I tried to adjust for the fact that I-SPY is an oncology trial by looking at some literature that told me oncology trials are generally 20% more expensive than trials in other disease areas. I think there would be a need to further sensitize different factors, isolating different factors, seeing what only per patient cost would do and what only per site cost would do. I think what's really important is understanding how our revenues would be impacted if we were looking at drugs in different disease areas. For instance, is there a greater revenue in the triple negative area as opposed to the HER2 positive area? And I think that's one of the key things that could potentially be driving value for our pharmaceutical companies, especially as we move into this area of targeted therapies. And so finally, I wanted to leave off with what I hope to do with this analysis. And what I really hope to do is use this data to see where I-SPY stands in comparison to other clinical trials, and then be able to see how can I-SPY continue to improve, and B, how can we leverage that so that our pharmaceutical companies are more incentivized to invest in I-SPY so that we can build a financially sustainable model and ultimately bring the right drugs to the right patients so that patients are getting drugs that are targeted to their particular disease. And that's really the direction where most cancer treatment is going and really the direction that we need to push our pharma companies to go into. That being said, I wanted to thank everyone who's helped make this year a great year. I told Laura I would end with what I learned, and I think what was really exciting for me this year working on I-SPY and also the Healthcare Value Retreat, and hopefully next year on that too, is understanding how I could leverage where kind of I came from in terms of my background and bring that into the medical space to really create efficiencies, cost efficiencies, operational efficiencies. And what essentially happens is that really does trickle down to the patients. If we're able to create more sustainable models, if we're able to improve quality, we can really provide a benefit to our patients. So thank you.
Okay, that's great. So Mamta, I have a question for you. So looking at your analysis, if you think about the biggest levers that we have, it is, so time. It's probably not the cost per patient in a phase 2 because it's not so big. So a couple things is the sojourn time for a drug in I-SPY 2. If we made that shorter,
that would increase. Like if you, so average what I found was about 2 years for phase 2, and if we can get that down to 1 year for phase 2, and if we can shave 1 year off of a phase 3, then you're shaving 2 years off of your time to development, and that's how you really increase your value. It's not so much necessarily the cost, and that makes sense because if you're looking out, right, you get $100 million by having an extra year on the market, whereas you're only saving costs like $20 million, and so that's kind of why time impacts has a greater impact.
So it should make us think about, you know, whether we have 2 drugs or 3 drugs in the trial versus 5. The sojourn time or the throughput is much faster when you have fewer drugs in the trial. So that's actually.
Or you increase the number of sites, as she showed, site costs don't impact your overall cost, so in overall patients.
Well, we could do that too. Get a little bit more revenue first. Someone gives me $5 million. Anyone of us spare $5 million anywhere, I'll take it. One last question, and that is, so this is a model where your patent life is what's driving, right? What happens when the standard of care changes more rapidly? Let's say that we get to the point that we accomplish our goals of really driving change in a much more rapid fashion. So you're effectively truncating your patent life. What happens when time to market?
Yeah.
And you're going to have a period of exclusivity that's always going to be limited. What's going to drive value there? That's for next year?
I'll think about it. I'll let you know.
We'll be lucky to have that happen, but I think that's coming. Hopefully, we'll try and make it come. Okay, thank you.
Hi, my name is Dominic. I'll be a second-year intern this coming year at the BCC. And one of the things I learned this last year is the importance of being proactive and the benefits of being proactive. And I think this is a lesson that all the incoming interns keep in mind. There are so many opportunities here. You just have to show up every day with the energy and kind of hunger to get involved. And you'd be surprised what you can accomplish in 1 year. So today I'm going to talk a little bit about immune signatures in breast cancer. A little overview of my talk. I'm going to first talk about the background, about the immune system and breast cancer in general. And then I'm going to dive into my project specifically, which is an immune signature analysis. And then I'm going to talk a little bit about the applications of that project and the next steps. So, as many of you may know, the immune system is very important in cancer. In particular, the tumor immune microenvironment is incredibly complex. T and B cells, proteins such as interferons, polypeptides such as transforming growth factor beta, core serum response factors, which has to do with wound healing, all play into the tumor immune microenvironment and the way the immune system interacts with a given tumor. In particular, T and B cells infiltrating a cancer has been shown to be good for survival in breast cancer. And in some cases, it's hypothesized to be triggered by chemo or other targeted therapies. The idea that you can control or modulate the immune system using a therapy has spurred an interest in immunotherapies. And these therapies are these therapies basically strive to target immune checkpoints, specifically to allow the immune system to attack cancer, unleash itself on cancer. As a result, there are a growing number of trials for immunotherapies in breast tumors. However, with all these trials, there's still no reliable immune biomarkers. That is, we don't have a good way of seeing or predicting which patients might or might not benefit from a given immunotherapy. Fortunately, with the growth of interest in immunotherapies, there's been another growing interest in these things called immune-related expression signatures, and those could potentially be the immune biomarkers we're looking for. And so for those of you who don't know, immune-related expression signatures, or immune signatures, are basically just a group of genes that are all associated with some aspect of the immune system. So one signature can encapsulate many, many different genes, all of which together represent or try to quantify some aspect of immune activation. The reason we have immune signatures is because we have this technology called microarrays, which allow us to measure many genes at the same time. And so what you see here on the right is an Affymetrix microarray, and the different colors basically just represent higher or lower activation levels of different genes. And so just so everyone kind of knows what an immune signature is, this is an example. The signature's name is IR7. It's composed of these 7 genes listed below. Thanks to microarray technology, we can quantify a value for each of those genes, the expression of each of those genes for any patient. And all those genes together try to quantify some aspect of the immune system. And so if we take the mean of these genes, we can calculate a score for every patient. And so here you see patient 1 has a score, an IR7 score of negative 3.36. Patient 2 has a different score. Patient 3 has a different score. I also listed a second signature. You can imagine this one's called BUC14. And that patient's got a different score for that signature as well. The values can be negative because the data is median-centered. So this has been an example of one immune signature, but actually there have been many, many, many signatures published in literature. There have been actually over 50 signatures published independently in literature, all purporting to describe or understand different aspects of the immune system in breast cancer and other cancers. Also, the plethora of immune signatures are suggested to predict breast cancer prognosis or survival and chemotherapy response. However, with all these independent publications, the relationship between all these different signatures remains unclear, and whether some, if any of them, can be used as immune biomarkers remains to be known. And so for my project, I looked at how do these published signatures relate to one another, and which, if any of them, might be used as immune biomarkers. To do this, I looked at correlations between 57 published immune signatures in 5 publicly available breast cancer data sets. It was roughly 4,000 patients, and all these publicly available data sets had information on the microarray data for all these patients. So I was able to calculate the 57 signatures for each of the patients we studied. And what we found was, even though there are 57 signatures, really they collapse only into 4 different immune modules, or 4 different categories. So what you see here on the right is the list of signatures I looked at. And we used consensus clustering to see which of these signatures were co-activated together or most related to each other. And what we found was they fall really into only 4 distinct groups, indicated here by the colors. And when we looked at these 4 different groups in more detail, we saw that there were common themes among the signatures within each group. So we decided to name each group based on the theme of the signatures that comprise it. So what we saw was, for the pink group above, it said all the signatures that comprise that group had to do with transforming growth factor beta, so we decided to name that module the TGF-beta module. All the signatures in the red group mostly had to do with T and B cell activation, so we named that module T and B cell module. We saw in the black group that most of the signatures had interferon activation, or were associated with interferon activation. And in the final group, we saw that most of the signatures were associated with core serum response. Again, these different modules are just different components of the immune system and activation in tumors. So basically, so far, what we've seen is that 57 signatures really just collapse into 4 modules, but we want to see what this means for patients. So we calculated module scores using the signatures for each patient. So we ended up with 4 scores, 1 for each module for every patient. And we wanted to compare the patients to see if there's any differences in the immune activation of the different patients. And what we saw was that patients really fall into 5 immune subtypes based on the differential activation of those modules. So what you see here on the far right, those are the 4 modules we determined from the signatures. And then at the top are all the patients we studied clustered by their differential activation of those modules. And what we saw was 5 different groups. The first group, in this figure, blue is low activation, red is high activation. We saw that we had one patient cohort had high levels of TGF-beta expression, but low levels of expression of the other 3 immune components. We saw a second group had high core serum response activation, but low levels of other immune components. The third group, the green group, had low activations of all 4 immune components. And we saw that another group had high interferon, high CSR, core serum response activation, and low levels of the other 2 immune components. And finally, we saw a group that had high interferon, high T and B cell activation, with middle and to low activation of the other two immune components. So this is just kind of a summary slide of what we found. We found 5 patient subtypes based on immune activation. Those are running vertically down. And basically the 5 different subtypes are just differentiated by the modular activation of the 4 different signature modules or immune components that we discovered. And so what's interesting with these immune subtypes is that they're associated with survival. And so what we see here is 2 survival curves from the 5 data sets we studied. And in both these sets, we saw that the blue patient cohort, which represents patients that had high levels of T and B cell and interferon expression, consistently survive at better rates than patients in the CSR high, or CSR high immune subtype, which is indicated by the black line in both the patient groups, or the survival groups. And so we learned that these immune subtypes are in fact associated with survival. But what we'd also like to know is whether or not they can be predictive of a response to immunotherapy. So we can decide which patients might benefit from immunotherapy and then put them onto that. And so that's kind of the next step for this project. We want to see whether immune subtypes or maybe representative signatures from the 4 modules we discovered might be predictive of biomarkers of response to immunotherapy. We want to test this in the neoadjuvant setting, ideally in I-SPY. And so ultimately what we learned was all these signatures really just collapse into 4 major categories. Those modules group patients into 5 different immune subtypes based on differential activation, and that has survival significance, and that these subtypes and representative signatures can be tested as predictive biomarkers in the neoadjuvant setting. So ultimately what we hope that this study did, and future studies will do, is help us understand immune activation of breast cancer a little bit better and understand which patients tend to benefit from immunotherapies. Thank you.
Excellent work. So, Dom, when you look at the survival curves and you look at the different outcomes for these different patient groups, if we are imagining, you know, there's a plethora of these new agents sort of coming on the market. The majority of these agents probably work to boost the immune response. Probably not to take people from no response to a response, but people who have some kind of intact response. So looking at those survival curves, who do you think is most likely to benefit from the drugs that are coming on the market?
It would have to be the T and B cell interferon high group.
Right.
Because they're the ones that have the best response based on immune activation.
Right. So like a drug like PD-1,
yeah,
which is taking the brakes off. Taking the brakes off means it presupposes that you already have an immune activation. So those groups, so that's particularly an important way that we might be able to identify those people who are most likely to benefit. Whereas now the combination, what's the opportunity the combination therapy is maybe to think about
the people in the lower lines. So like the CSR high,
right.
the immune low.
Exactly. So that's how we're going to sell our immune platform biomarker signatures to our pharma partners. They're going to love it. Yeah.
So these signatures, though, the patient subtypes of 5 groups still rely on all 57
right.
assays being done. So are you able to pick out representative, like single or a couple
right.
assays to do in a trial?
Let's hope not. Let's hope not.
Right.
We certainly can't afford that.
Right.
So the current thought is to take maybe one signature from each of the 4 immune modules. We did a separate analysis that showed that signatures within each module are highly correlated with each other, so it doesn't really matter that we have all of them or whether we just have one of them.
How reassuring.
That's good.
Are these independent prognostic factors for survival? These immune subtypes?
Are they independent?
Yeah. In multivariate analysis, does this come out as a significant factor?
Oh, it's like an independent from intrinsic subtype or
yeah,
stage,
the immune modules.
Treatment.
Yeah.
We didn't run a analysis adjustment for those factors.
But a number of groups have looked at that. These are independently important. That explains why Merck's entire portfolio is now dominated only by immune acting drugs. So, but I mean, I think it goes, you know, it's going to be a nice mix when we start to look at the expression signatures and we start to look at our ability to see where those B and T cells are when we have now our multiplexing. So Tess and Brianna's work on really looking at how to multiplex and see where all these immune agents, whether the T and B cells are in the tumor or not in the tumor. There's a lot of these. There's a number, you know, you can look at this in many different ways, right? And each one of these can be significant. So now we want to have simpler ways of understanding who has the signature, what does that translate into, where these T and B cells are, and how can we activate them. So if you were, I think let's add one more comment to that, is if you were going to distill this down, what is the simplest, cheapest expression signature or platform you can use to get those modules? Can you pick anyone? Can you pick AFI? Can you pick Agilent? Can you pick? Does it matter?
Oh yeah, I didn't look at a cost analysis between the platforms.
But if you, I mean, does it matter?
I
what
don't think
platform you
that
pick?
there are some artifacts between the different platforms, but the 4 modules we discovered were consistent across platforms.
We just have to pick the right signatures because some signatures are actually more sensitive to platform differences than others. So
If you pick platform independent ones?
yeah, so some work needs to go in if we're going to be trying to go for platform agnostic.
That would be great, yeah.
Yeah, because right now, what Dom didn't mention is that we actually covered all the platforms. So we have Agilent arrays, AFI arrays, as well as RNA-seq in there actually.
Oh, great.
And also Illumina, because that work is Illumina. So we have like platform coverage. So we could look into.
Those are all the different ways you can analyze the expression of the RNA in our RNA sequences.
And to answer the question, because these are public data sets, so not a lot of information about the other characteristics other than ER, PR, and HER2 is available. So unfortunately, we can't adjust for all the things we would like to adjust for when we look at survival.
First place
So does it matter that these are only the public available ones? I mean, if you looked at the non-public available, would you end up with the same result? In other words, is there a selection bias as to what's publicly available?
I think it's because all the reason why it's publicly available is in order to publish on an expression data set, then it has to be available.
So New England Journal, all the good sets have to be publicly available, or the big journals won't accept it. So I think the bias is probably for better sets, right?
You projected these out to 10 years, your survival results. So do you know the median follow-up of this group of patients, or?
I don't know.
That wouldn't be what you'd use for this. I mean, the first set we're going to look at actually in the neoadjuvant setting is going to be I-SPY1. They're going I mean, we actually already have the expression data, so it'll be pretty straightforward to do. Coming soon to a theater near you. All right, very good. It's been a great morning. Yeah, so we want to thank Amy again for supporting our intern program, and Meredith.
We're not thanking
Les-
you. So as many of you know, after 6 years, Natalie Cox is leaving us for greener pastures. She's taking on a teaching fellowship and finishing her doctoral degree. And although her departure is not till August, because she plays such an important role in the introduction and departure of interns and makes our lives easier, we just wanted to thank her today for all of her work and give everyone.
Okay, so thank you to everybody. It's been a fantastic morning. Okay, you new turns, you have big shoes to fill. You're in the deep end now, so start swimming. That's my advice to you. So we're here to help. Always with a smile. Anyway, it's a fantastic morning. Thanks to all of you for all of your hard work. We'll miss you. Keep in touch. Oh, and all the planners for the intern reunion. Next year, so if you have ideas, it's all going to be about healthcare value. These three.
It's all on Mount next year.
Actually, everyone is local, so Brooke, and Mamta working. And actually, Milan already came back. He sent a bunch of new ideas. We have to get everybody involved in planning. That's going to be what makes it. And best of the intern skits. Yeah. Okay, and at the potluck, I'm expecting the boys of the BCC and the reprise of Helen Miller. Okay, so that's fair warning and making sure it wasn't first or not better runner. So okay, bye everybody.
I have to jump on a call.